the HERC. We're recording. Today's June 12th. And we have confirmed we have a quorum. So we're going to go ahead and we'll start with roll call. Is that going to be?
All right, I'll go ahead and do that here.
Oh, okay.
Antoinette, looks like not here yet. Brian Duty.
Present.
Mary Angrod. Adrian Irwin.
Here.
Max Kaiser.
Here.
Lucy Langer. Looks like she's going to be absent. Sarah Love.
Here.
Chris Pinzone.
Here.
David Sanger. Not present. Katie Shable was not going to be able to make it. And Holly Jo Hodges.
Here. Mary Beth never responded, but she is here. Is she?
Mary, are you on? Mary Beth, are you on the phone?
We heard her once.
Might have to do *6 to unmute.
Because she's not working.
We don't have a quorum without her, so let's give her a moment. Is she still showing?
I just got an email. Oh, you know what? I see her phone number again.
Who's talking?
That's Jessica.
Okay, I think it's working. Can you hear me?
Yes, we can hear you. Is this Mary Beth?
Okay, I'm here. Yeah, I'm here. Thank you.
Excellent. We now have a quorum and we will proceed. Can you all hear us okay? Is this a better setup?
Sounds good.
We can hear you all really well,
Yeah,
so that's awesome. Okay.
The room is fine now.
Yeah?
Great.
Okay, so we'll move on to, for approval of the minutes.
Actually, let's do the conflict of interest.
Okay. Jason's out of order, just so y'all know.
Trying to check all the boxes here. If anybody has any conflicts of interest to declare, now would be a great time, but any topic on the agenda. All right. And then we can do the minutes if you like.
Okay, no worries.
Page
So
8 of your packet. Page 8.
Thank you. Page 8 of your packet will entertain a motion or any comments or corrections, and otherwise a motion to approve. So thank you. In a second, I have both Adrian and Brian, so we'll just take that. And now is Jennifer, who's gonna read the roll call for approvals?
Yeah, Jessica, could you read that?
Can do. So we have Brian Duty.
Present.
Do you vote yes or no?
Oh, yeah, sorry.
Sorry.
I was like, what?
It is hard to know where we're at some days. We're voting on the minutes. Brian is a
I
yes.
approve.
Mary Beth,
Here.
do you approve of the minutes or not?
Yes, approve. Apologies.
Adrian Irwin,
Approve.
Max Kaiser,
Approve.
Lucy Langer.
Lucy's not here.
Oh, Lucy's not here. That's right. Sarah Love,
Approve.
Chris Pinzone,
Approve.
and David's not here. Katie Shable,
Here. Also absent.
also absent. Oh, that's right. Okay. Holly Jo Hodges.
Approved.
Motion passes. Or minutes are approved.
Minutes are approved. Great.
Excellent, thank you. Jason.
Orientation presentation is good.
Sorry, it's not in the point, so I'm gonna grab it. Yes.
Well, I'll go. I think I have it almost memorized by now. So we're here for the Value-Based Benefits Subcommittee. The purpose here today is to make recommendations to the Health Evidence Review Commission about coverage and medical necessity for the Oregon Health Plan. We'll also be reviewing a coverage guidance produced by the Evidence-Based Guidelines Subcommittee and considering changes to the prioritized list. As a reminder, OHA has set a goal to eliminate health inequities by 2030, and these decisions will affect over 1 million Oregonians as well as their families, caregivers, and providers. No decisions about individual care today. Decisions are not final until approved this afternoon, hopefully by HERC. will be implemented at later dates. In general, we're looking at considerations such as the assessment of the balance of benefits and harms, patient values and preferences, stewardship of public resources, and the nature of healthcare delivery system. And all those informed by our published evidence, peer-reviewed evidence, as well as expert opinion and public testimony. Go ahead. Members, if you please be on camera and attentive as much as able. If you need to step away, please message Jessica so we can keep track of quorum. Or if there are logistical issues, we will be voting using a roll call today, just as you saw a moment ago. And if you need to, please avoid using the chat for meeting discussion, just so everybody can hear. And we just have one discussion going on. So just raise your hand or speak up if you have something to say. And for those offering testimony, make sure your Zoom name matches your registration name so we can promote you at the right time. And then other people, members of the public, can use the Q&A feature in Zoom to ask questions. Daphne's not able to be here today, but one of us will address it as we are able. And those, anything put in the chat or the Q&A or said on this is part of the public record. This meeting will be posted online in a few days. Next slide. And if you have any feedback, questions, concerns, herc.info@oha.oregon.gov is the best way to reach us. All right.
All right. Straightforward consent agenda.
Oh, do you want to do the staff report?
That's what I meant.
Okay.
Sorry, staff report.
So we were supposed to have a listening session last night. That got canceled. We just haven't had a lot of topics lately. I'm not sure why. Daphne's getting some inquiries, but she's routing them to more appropriate venues. So we'll continue to schedule those because we do get topics through that, but we haven't had as much interest recently. Legislative update is kind of the same as last time. The bills that affect the commission are in Ways and Means, Joint Ways and Means, and the revenue forecast was not as good as expected. And so we'll see if any of those move because of the budget recommendation. Our decision framework we discussed in April. Not quite ready to bring that back. I'm hoping we can bring that back to the commission in August. And recruitment is still open for several new membership. We've had some interviews already and we have a couple more scheduled. Seems like a strong pool of candidates, but more to come on that. And finally, we're hosting something new, technical office hours. And this is aimed at like IT and administrative systems people related to the benefit update project and some of the technical changes that'll be made to our file structure. So we won't be talking about budget. We won't be talking about clinical issues. This is mostly for IT folks and administrative folks. So if you know somebody who has a system built around the prioritized list, please encourage them to consider attending that. And it's really kind of an ask me anything. Any questions about the staff report? All right, Ariel, take it away, live from another time zone.
Good morning, everybody. Can you all hear me okay in the room? Okay. So the first item on our agenda is the straightforward. We just have one.
Page 76.
Thank you. One single thing in our usual consent table. And then for our straightforward guideline note changes, there's a couple of just clarifications, really. One about corticosteroid injections, and then we made some changes at our May meeting about the circumcision guidelines. And this in the meeting materials was effective 1/1/27. However, at HERC, they asked that we have this effective 10/1/25. And so this is just a technical change to allow this to be effective 1/1/25. It's the same material that you saw in May. Any questions about any of the straightforward items? Of these two, we have one more straightforward item. And the third straightforward item is telehealth for preventive medicine services. Metropolitan Pediatrics is using the 99401, those preventive medicine health codes for some preventive services for some of their members, and they asked that we add that to the codes eligible in our telehealth guideline. We have an example set of codes, adding that set of codes to that as an example. Any questions about that? All right, that's the straightforward package.
Ariel, there's the errata as well.
Oh.
Oh, I don't think we had any errata.
We do. There are a couple of just corrections. They should have been, they're on the screen in front of you. Does anyone have any, they're basically just corrections. Anyone have any questions about any of those?
Oh, thank God, the mislabeling's fixed.
So I was-
All right. So anyone want to move to approve the straightforward agenda?
So moved.
Thank you, Brian.
Second.
Adrian seconds. Roll call to approve. Jessica?
All right. Brian Duty.
Aye.
Right. Oh, you're back. Okay. Oh, wait,
Um,
we lost Max. I think we need to wait on our vote. We
Oh.
lost.
one moment then. Let me check for Max.
No, Max was in the room, but he stepped out.
Oh, okay. So I thought, never mind.
I think let's go on with our agenda and vote again on that later. Not sure.
We'll come back. So we'll move on to new discussion items.
Yeah.
Page
so
84.
Thank you.
So we have two new discussion items that are related to sleep medicine, and we have a sleep expert who should be here virtually to answer any questions from you all. And we'll introduce her in a minute. The first of the two items is hypersomnia, which is a condition in which you sleep too much. You have an irresistible need to sleep, or you feel non-refreshed after sleeping for a period of time. There can be central sleep disorders such as narcolepsy, and then there are other causes, head trauma, viral illnesses, etc. These are different from just feeling really sleepy because you are ill or haven't slept in a while and you're tired. This is more of a chronic kind of condition. There are treatments that are behavioral, like scheduled naps. But then there's a lot of medications, modafinil, and many others are used off-label. A new one has received FDA approval of sodium oxybate for idiopathic hypersomnia. And then stimulants that are typically sort of considered for ADHD are also used for hypersomnia. PNT staff have been reviewing this topic because of the new approval of sodium oxybate, and that we look into this condition. And then serendipitously, Dr. Henderson, who is with us today, reached out through the staff listening session process about concerns that she had. She is a sleep specialist, about hypersomnia and its impact on quality of life, and the fact that it's currently below the funding line. And she was requesting consideration for medication, CBT or counseling, and sleep medicine visits for the patients with this condition. We reviewed hypersomnia last in 2011 as part of the ICD-10 conversion. At that point, narcolepsy, which is that condition where you just drop and fall asleep, was thought to be a disabling condition with effective medicines, and it was moved to a covered line. But hypersomnia was thought to need medications, but it was left on its unfunded condition, although it was considered to have a similar impact to other conditions like insomnia, which we have recently moved. There are, of course, multiple ICD-10 codes, as there always are, for various types of insomnia or hypersomnia, some of which are like insufficient sleep syndrome, which wouldn't be what we're talking about. We're really talking about the hypersomnias that are more of a long-term medical condition. So currently they're online. They're on an unfunded line, $5.99. Narcolepsy is on line 201. So for hypersomnia, if you had a medication like modafinil that was not on PA, you could get coverage for it, but it is non-funded, so it could be denied if it went through a PA process. So looking at the evidence, there was a review in 2023 of idiopathic hypersomnia, and they looked at various interventions, including patient education, exercise, and various medications, and all mentioned that this is basically just a general review that these were noted treatments. There was the American Academy of Sleep Medicine position statement. It's currently in the press, but is due to be published soon. This was provided by Dr. Henderson, and the American Academy of Sleep Medicine noted that sleepiness is a critical patient-reported outcome, has many adverse health effects and diminished quality of life, and can have many impacts on mood, safety, etc. So the American Academy of Sleep Medicine's expert guideline, which was published in 2021, they recommend modafinil with a strong recommendation. They have conditional recommendations for a variety of other medications. And then they also note that hypersomnia can be related to underlying medical conditions like Parkinson's disease, and obviously you would want to treat the underlying condition. And then they did note that there's still recommendations for treatment even for non-idiopathic, so if it's related to like a head trauma, etc. The private payers that I could find policies for do cover hypersomnia. And then Dr. Henderson is here, and we'll hear from her in just a second. She did provide some public testimony or a formal written comment as well in support of the staff recommendation. We did a claims search. Hypersomnia unspecified, we normally don't like unspecified codes, and that had the most claims. And it turns out, according to Dr. Henderson, that CMS or Medicare is requiring this for certain sleep studies, et cetera, if you're worried about hypersomnia, which is probably why there are so many claims for that specific diagnosis. So essentially, hypersomnia, it's a central nervous system disorder. It has significant adverse effects on daily living. Modafinil is a recommended first-line treatment. There are other medications, including a new FDA-approved medication, sodium oxalate. It appears that this condition is similar to insomnia for impact on quality of life, and the staff recommendation is to move the codes for hypersomnia to the same line that has insomnia, line 201, and change the name of that line to include hypersomnia in the list of conditions that are on that line. Any questions for me about the issue summary before Dr. Henderson? We introduce Dr. Henderson. Any questions for me? And Dr. Henderson, did you manage to get promoted and all that other stuff?
Yes, I did.
Okay. If you could just introduce yourself, we ask that you state your name, any organization that you're affiliated with or representing, and any conflicts of interest you might have.
All right. Well, hello, I'm Jennifer Henderson. I'm a sleep medicine physician for Asante down in Southern Oregon. I don't have any conflicts of interest. And so really, I'm just bringing forward hypersomnia because it really does need treatment. It is being coded for way more often than we actually see it because Noridian has required for us to have diagnostic codes of obstructive sleep apnea unspecified, or hypersomnia for any coverage of sleep studies. So all referring providers are being asked to use one of those three diagnostic codes, thus hypersomnia is being used over and over. But when we actually have a hypersomnia patient, we specify down further to idiopathic hypersomnia or hypersomnia due to a medical condition. And so those are the patients we're asking to be able to treat. Sorry, did somebody have a question? So hypersomnia is whether it's idiopathic or secondary to a medical condition, is just as debilitating as narcolepsy is. In fact, these patients tend to be actually harder to control because they have this overwhelming drive to sleep. They have trouble waking up in the morning because of the severe sleep inertia they have. And it really prevents them from doing just their own activities of daily living, maintaining jobs, things like that. But we actually have really good treatments that allow them to be functional and enjoy their time with family and to work. You know, the modafinil does help promote wakefulness. The sodium oxybate, it's a medication they take at night that actually helps to promote better sleep architecture, which of course the next day allows for better wakefulness. And so we'd just like to be able to have access to these medications for these patients to allow them to be able to be functional during the day and engage in the activities they need.
Any questions?
Yeah, hi, I may have missed it. Could you just give us a little background on what's the physiologic difference between narcolepsy and hypersomnia?
Yeah. So they kind of are a spectrum. So narcolepsy type 1's the easy one. That one is an autoimmune disease. We can either diagnose it with an MSLT or we can actually do a lumbar puncture and look at the orexin, which is also hypocretin levels in the cerebrospinal fluid. That's the one that actually has the cataplexy with it, which is the sudden muscle weakness. Narcolepsy type 2, we diagnose with a daytime sleep study, a multiple sleep latency test, and it's kind of the in-between of the two, of type 1 and the hypersomnia, meaning we usually see at least one early onset of REM, which is also one of the defining features of narcolepsy, is that their sleep architecture is so fragmented and disorganized, they go into REM sleep almost immediately upon falling asleep. And so in narcolepsy type 2, they're excessively sleepy. And when we do these sleep studies, we see that they go into REM more than the average person as soon as they go to sleep, but not quite to the level of the type 1. It's kind of a gray zone we don't quite understand. Hypersomnia, these are patients who are excessively sleepy, even if they've had sufficient healthy sleep at night, meaning if they have obstructive sleep apnea, they're using their CPAP, they've allotted enough time to sleep at night, but they still struggle to wake up in the morning. That's one of the key features, is they have this ongoing sleep inertia. And then they are sleepy throughout the day, often to an overwhelming point where they may fall asleep in meetings, fall asleep driving, fall asleep eating even. Of course, there's varying levels of it. And so it's just an overwhelming drive to sleep that is requiring much more sleep than is actually physiologic. And also, even if they get sufficient sleep, they are often still have this overwhelming drive to sleep throughout the day.
And we believe this is neurologic
Yes. Yeah.
in origin. Okay, and it is
Yeah,
distinctly different and diagnosable separately from narcolepsy.
Yeah, so when we do the multiple sleep latency tests on patients with on any sleepy patients, that is the daytime test where we give patients the opportunity for 5 naps. Before they actually have that test, they have to keep a sleep diary or use actigraphy to track that they are actually getting sufficient sleep for at least 2 weeks leading up to it. Um, we take them off medications that would possibly cause sleepiness. They have to have an overnight sleep study beforehand to make sure that there's no sleep apnea we're missing, or if they are on a CPAP, that their sleep apnea is truly controlled. And then they have this 5 nap opportunity test the next day. And what we look for is that they fall asleep in every nap. Well, for an average, we call it mean sleep latency test because it's an average, in less than 8 minutes. And so we average the 5 naps. Now, if they fall asleep and go into REM sleep once during those 5 naps, then it goes in the narcolepsy type 2 category. If they fall asleep and go into REM sleep 2 or more times, it goes in the narcolepsy type 1 category. If they don't go into REM, but they still are just falling asleep in all these naps and have that mean sleep latency time less than 8 minutes, then it falls under hypersomnia.
Thank you. Other questions, clarifications? All right, thank you very much. Back to you, Ariel.
Yeah, so any questions for me, and how do you want to vote on this separately? Or do you want to vote on this with the other new topics, or how would you like to handle this? Oh, and I see your hand up, Chris.
Yeah, I was just curious. Right now, you said that they don't have access to these medications. Is there an alternative that you are using? And then for Ariel, since we don't do medications, if we moved it to a covered line, does it still need to go then to the P&T committee?
No, PMT's been working on this. They actually already are they have draft work on this. They would move it, they would have recommendations for exceptions or for children through EPSDT, that type of thing. And then they would, if we move it to a covered line, then we'll work with them and they can do the whatever they need to do on their end for the PA criteria, et cetera. And they're aware that we're doing this. And
Great.
just for everybody, I was just informed that it's not sodium oxalate, it's sodium
Oxybate.
oxybate. So I apologize. It's not a huge issue. It for you all. I guess the pharmacy folks might worry about that.
It probably matters at the end. So Ariel, why don't we take hypersomnia and insomnia together, since that seems to make sense to me. You can present that, wrap that up, and then we can vote on those. And then I'd like to vote on the rest of them separately.
Perfect. So the next one is insomnia. You'll probably all remember we've discussed this a couple of years ago and we moved it to the covered region.
Page 90.
This is also a request that comes to us from Dr. Henderson. Currently, so insomnia is the inability to fall asleep, maintain sleep, or return to sleep after early morning awakening or some combination thereof. It's frequently coexisting with mental health disorders like anxiety or depression. It can be just a condition on its own, however. Usually diagnosed with sleep studies or sleep history. There are prescription medications. And the Z drugs are the sort of classic, Zolpidem and those types of drugs, as well as over-the-counter medicine like melatonin and diphenhydramine. There are also good sleep hygiene instructions, as well as cognitive behavioral therapy can be used to discuss this. Actually, this was a while ago. We actually discussed this in 2016, but didn't add coverage. And then in 2022, an evidence review found, high quality reviews found moderate evidence that cognitive behavioral therapy for insomnia, CBTI, is effective at treating it. Pharmacologic treatments have low quality evidence that they're effective in the short term for less than 3 months, but they are related to long-term harms. And expert guidelines recommend using pharmacologic treatments only when CBTI is ineffective or in conjunction with CBTI. Based on that review, we added coverage for insomnia with a guideline that states that short-term, up to 1 month per year with sedative hypnotic medications is included for insomnia only if a patient is currently in CBT or has failed to respond to CBT in the past year. And Dr. Henderson brought this topic to us because of concerns that in her area in Southern Oregon, there is only 1 or 2 CBTI providers. It's very difficult to get into CBTI treatment. There's also, there are free apps and other technology that you can use to get to CBTI, but you need to have a cell phone or a computer and internet access. You need to speak English generally, and you need to have a reasonably high reading level to do to take part in the online types of CBTI, and that this is just difficult for many patients to do. So she was requesting that we modify our current coverage to say not just during CBTI or if CBTI is not effective, would you have access to medications, but also if you can't access CBTI. So looking at an updated evidence review, the American Academy of Sleep Medicine in 2021, their clinical practice guideline, they have a strong recommendation for CBTI, as well as for a conditional recommendation for briefer forms of CBTI, and multiple things like sleep restriction therapy, which is a portion of CBTI. So they're still highly recommending that. As well as the American College of Physicians also continues to recommend CBTI as first line. And then medications should be a shared decision-making approach. And for expert input, I kind of summarized what Dr. Henderson was mentioning, and also working with our pharmacy colleagues, looking at some of these medications like Zolpidem and benzodiazepines. Many of these are actually very inexpensive and people can pay cash for them even if they don't meet our guideline. And there's some concerns about side effects and issues with Zolpidem. So in summary, CBTI is effective. It is the preferred treatment in all of the major expert guidelines for insomnia. However, they're based on expert input as well as speaking to other providers in the community. CBTI is not necessarily available to a lot of the OHP population. And for example, they don't have the right language, they don't have a provider, they don't have access to the phone apps, etc. Also, Dr. Henderson was asking for more than 30 days of treatment for medications such as doxepin or suvorexant, which are suvorexant's one of the newer insomnia medications, which has a better safety profile. And we have put her in touch with P&T to discuss those medications. So the staff recommendation is to modify our current insomnia guideline so that you need to either be in CBTI or have failed to respond in the past year or be unable to access CBTI in order to get the 30 days of treatment. And then we had mentioned this when we were discussing this a couple of years ago, that you can do CBTI through an app or a book. And so that would just be clarified that that is an option in our guideline if there's not a provider who is skilled in CBTI that's available to the patient. The staff recommendation is to leave in the long-term treatment with sedative hypnotic medications, and that's working with our PNT staff, thinking that some of the medications that are used longer term are really more in the antidepressant or other categories. They're not necessarily sedative hypnotic. Any questions for me before Dr. Henderson can make some remarks? All right, Dr. Henderson, take it away.
All right. Completely agree. Cognitive behavioral therapy is the best treatment for insomnia. We would rather every single person gets that. The issue is, especially here in Southern Oregon, we have one cognitive behavioral therapist who's trained specifically in insomnia. She does not take Medicaid, and she's booked over 6 months out, even for her group courses. We have finally got 2 others that are actually based out of the Portland area that can do this online, but our patient population has a really significant illiteracy level, also very high Spanish speaking population, and we don't always have internet access in our more rural areas. A lot of our patients live off grid. And then just geographically, with our geographic features, internet can be difficult to access. So it's just not quite fair to ask a lot of our patients that they have to have this at the same time or beforehand, because they just don't have access. It's just not a reality to their situation. And the fact is studies have shown that untreated insomnia increases the risk for anxiety, depression, suicidal ideation. And so we have safer medication access now, and that's kind of what we're asking for, is coverage for that, because what ends up happening is there's no coverage for the medicines really. So the patients end up getting zolpidem or a benzo from their primary, and that's actually a much more dangerous alternative because they're cheap and they can afford to pay for them out of pocket. Where if we could get coverage for medications like low-dose doxepin or any of the dual orexin receptor antagonists such as suvorexant, these medications have been shown to be far less dangerous. For example, the doxepin is just an old antidepressant, and at 3 to 6 milligram dose has not been shown to have the dementia association. The suvorexant, even though it is controlled and it was initially that class of medications there was some concern for respiratory depression, follow-up studies really have not seen that to be a significant concern. And in fact, there's actually quite a few studies going on right now because it appears that using suvorexant with buprenorphine and in those recovering from opiate addiction actually helps to reduce their risk of relapse and without causing significant respiratory depression. It also it doesn't have much of a street drug street appeal because it wears off quickly. It does not induce a high. And so we have these options available now that if we could prescribe, they'd be so much safer. And we do have a brief behavioral therapy for insomnia program that we are able to get our Medicaid patients into. So we are still utilizing behavioral therapy, But there is also this reality that it is time consuming, it's limited access, and it's not fair to these patients to tell them, well, sorry, you just can't be treated because you don't have access or you can't read or you don't have internet. When we know that if we treat their insomnia, they are more likely to be productive and have a better quality of life.
And just as a note for everyone in the room, HERC staff have been working with our PNT colleagues, and we have connected Dr. Henderson with them. So some of the discussion about which agents will be covered is kind of happening in a different venue. This is really more of a allowing people who can't access CBTI to not have that as a barrier.
Great, thank you.
Yeah.
Go ahead, Max.
If they couldn't access CBTI, would it be reasonable to suggest or require those other conservative therapies? So I know sleep restriction therapy is not fun, but you can explain it pretty straightforwardly, or some of the other relaxation techniques or sleep hygiene. Would that be accessible by your population if we included those as well?
To an extent, it is. Like I said, we actually have a brief behavioral therapy clinic, but it's one person. We do, all of us as providers do discuss those things with patients. But quite honestly, with all of the sleep clinics closing, not all of them, but most of the sleep clinics closing around us, the volume is a bit overwhelming as well. And being able to stop to give true counseling and things is more than we can do while still maintaining the care we need for such a large population. We all definitely cover it during each of our visits. And then like I said, we have this clinical sleep educator to back us up and meet with the patients as well. But we don't have the counselors that provide the even deeper benefit. But those are all topics we all talk about at pretty much every visit with every insomnia patient. So those are just blanket being addressed.
So would it still be reasonable to expect after an initial visit that somebody would spend 30 days working on sleep hygiene and some of these other things? I think what I'm concerned about is that the easiest thing is to write a prescription.
Mm-hmm.
And long term, that's not sustainable. So would it be reasonable to, as Max said, require sleep architecture, sleep habit discussions and 30 days, 90 days of trying that, or?
I think that would be very reasonable, yes.
Okay, great, thank you.
This is Chris. With adding the virtual option or doing the app, will that open up access in a meaningful way for your population? Because you mentioned quite a few other barriers, and I'm wondering if there are other ways to address those barriers that you've thought of.
So we've been trying to utilize those options for a while. So the app, we actually recommend apps already. That's actually in our handout that patients get as they leave if they have an insomnia diagnosis. Most of the apps are only in English. So that is a big limitation for our Spanish speaking. And like I said, there's a very significant illiteracy rate down here. I have quite a few patients who can't even read their our questionnaire for them to fill out to come in. A lot of patients are at about a third grade or lower level. And so that's the difficulty with apps. Then we get to the online. Most online counselors we have found will not take Medicaid. So that is another big limitation. We are constantly looking for more, but that is one problem. The other is that it requires a reliable internet connection and the ability to get online and have the either computer or smartphone to be able to engage. That is probably less of a problem because there are areas where you can access Wi-Fi. We've always had iPads available for patients to do those kinds of visits and things. But more than anything, it's access to providers that will take Medicaid when it comes to counseling.
So it's not even language, like you have access to interpreters. It's really the specialty.
Yeah.
And
Yeah.
Chris, I would echo that in the Portland area, trying to find a person who's skilled in CBTI, I have not been successful. That's in Portland. Maybe I'll ask Dr. Henderson who her contacts are in Portland.
I am happy to share, though. I wonder if we're overwhelming them already. But yeah, they were just two providers in the Portland area who got a hold of us. But I think they take Medicare, but not Medicaid. I had to not see Medicaid listed on their list.
I'm wondering, do you know if the new, I think it's Oregon, the new behavioral health center that opened here for Oregon University, if they have even some like student-based clinics that might be able to, I'm just curious. I know they're very new, so
I haven't had any experience with them. I do know that patients that were referred to OHSU from our area for insomnia are denied.
not OHSU. This would be
Okay.
oh gosh, they bought the Concordia campus. Oregon University, I think. It's a
The-
Ducks.
It's the University of Oregon.
Thank you, University of Oregon.
I'm sorry. Yeah, this is the first I've heard of it. I don't know.
It's brand new. I don't think they know what their curriculum is yet.
Oh,
Got
okay.
it. Thank you.
Go ahead,
Do we
Adrian.
have past precedent for, like, I see the access discussion. I'm trying to think through if we've ever written into a guideline note that if somebody is simply unable to access it, then we enable access. And I'm struggling with other places that we've handled these types of logistical challenges in a similar way.
We've done that with the low back pain guideline.
Yeah, and we've done that with like some of the urology, or a lot of the surgical ones, either, the patient's is not a candidate or unable to, yeah. The back pain one is a good one if they're unable to access exercise or yoga.
We did write that for low back pain, that if they're unable to access it.
Right?
Or I think we just said if it was available, they would.
It's the massage that's
They-
if available, I think.
Yeah, nonetheless, a lot of this is beyond our scope. We recognize it's a problem statewide. That doesn't mean we lower the quality of care. If you get.
We did change band to band stuff.
But does it, if we're setting the guideline to be sequential and they can never pass the first bar, are we leaving
I don't
the
think that's what this does.
Okay.
What we're asking,
Best attempt.
there's always been, you always can start with the discussion, like Dr. Henderson talked about sleep architecture and sleep habits, and all of those things should always be the first place that one starts.
Yeah.
As opposed to going directly to script.
Well, and I don't know of any sleep doctor that doesn't approach it that way, because we know that that's a better long-term outcome than medications. But I think it is important to note that there is actually a subset of patients who have had insomnia since childhood, and they have been shown to require both long-term cognitive behavioral therapy and pharmacology to actually be managed, that they will not respond to one alone. And there are studies that show that too. So if we want to even break it down further into subgroup of patients, it's more that we need the access to pharmacology for those who need it with behavioral therapy, or who have absolutely no access, or we have at least done the brief behavioral therapy that we can do as providers and within the clinic we created for this reason. But that there's just not any counselors to do the true cognitive behavioral therapy for insomnia.
Is there evidence that shows that doing CBT with an app or a book is equivalent to doing it in the office?
They're not with a book, as far as I know. There are online programs and apps that have been used that have been shown to be non-inferior if the patient is engaged.
It's a lot of ifs.
But that's true for any counseling, right? You have to be engaged for it to not just be somebody talking to you.
Exactly. Other thoughts, discussion? Adrian has a deeply furrowed brow.
I'd be open to adding if CBT isn't accessible, that those other therapies, so relaxation therapy,
Max, I can't hear you.
Okay, I'd be open to changing it to, if CBT wasn't available, adding that extra caveat for those other behavioral therapies. So sleep restriction, sleep hygiene, relaxation therapy. And the Academy of Sleep Medicine, it says they recommend all those, just not sleep hygiene by itself. So I think those are
Oh,
all
yeah.
reasonable and recommended.
For sure.
So requiring documentation of education on all the
Yeah, I
other.
guess the question is how long of a trial? Because we don't even say how long of a trial is CBT, right? We just say they have to have failed CBT with the
No,
assumption that
short
CBT is
term.
not short.
CBT, I think
Short
it's
to up to a month.
I think it's like a 6-week program, maybe.
Depending on who sets it up, but yes, it was originally designed as a 6-visit program. When kind of the formulaic model was designed about 30 years ago through, I think, Duke and the VA. So the spacing between those visits kind of depends on the provider. Because like, for example, so we do engage in quite a bit of it to the extent that we can as physicians. So if I have a patient who I've given a sleep restriction schedule, but I know they're going out of town for as soon as they're done with their with me for 2 weeks, I'm not gonna put them on it when they're out of town because that's just inviting failure. So I'm gonna say, okay, well then I'm gonna see you back in 4 to 6 weeks so that you've had 2 to 4 weeks to follow this schedule at home first. And then we talk about where your barriers are and what we can change. So can be quite a bit of variability there between spacing.
So short term, 4 to 6 weeks per year treatment.
Isn't the short term there just for?
No, that's for the
That's for the
sedative
meds.
narcotics, yeah, that's. For
Yeah,
the meds,
it's not for
right.
the CBT. We didn't put a timeline on
CBT
CBT.
has no time.
Yeah.
Oh, I just see CBT right next to short term and assumed they were connected.
It weaves in discussing CBT and medication.
Okay, maybe
Yeah.
we need to straighten that out a touch.
Yeah, I think we could kind of wordsmith it later because I know we have a lot of stuff, but if something along the lines of 6 weeks of those alternative therapies,
So
if
what I'm
CBT isn't
hearing,
accessible.
Max, is I can work offline with Dr. Henderson. So if you're unable to access CBTI, there needs to be documentation on the record of 4 to 6 weeks of education on sleep hygiene and sleep restriction and
Yeah, I'd say sleep hygiene and one other therapy because the Academy says don't use sleep hygiene alone.
Which I fully agree.
Perfect. Well, if you're helping write it, great. That'll make the most sense.
And so with that, and this.
Again, back to none of us want to just write meds. We would much rather see
Yes.
long-term behavioral change.
Just like any guideline, we have to write them kind of what is ideal. Yeah.
But just to be clear, this only limits the sedative hypnotics, not the other classes of medications you mentioned. Those have their own criteria, right?
I mean, we're not really touching meds because that's P&T. We're just saying they gotta fail behavioral therapy or CBT before they can move to meds, and then what
Before they
meds, what
can
time
move to
limit is.
these meds.
To
Although-
sedative hypnotic medication.
PNT is limiting sedative hypnotics for insomnia to 30 days based on this guideline. So that would be benzos, zolpidem, Lunesta, those types of medications. So they are limiting those. But again, people can pay out of pocket. They're pretty inexpensive.
But we
Would
want to
it-
avoid
Would it add those other?
medications.
But the point is, they shouldn't be done long-term because of long-term complications.
And effectiveness.
Safety concerns and we don't know if they're effective or not.
Right.
Right.
So let's table this.
I see
And bring it
Chris's
back.
So the request was actually that we have access to the other categories of insomnia medications and be able to use those long-term because they don't have the same safety risk profile. Because sometimes long-term medications are required, especially like in TBI patients and things like that. But we'd rather get away from those. We agree. We don't want zolpidem long-term. Those are not our request. It's for the safer medication options.
Right, and you've been directed to P&T to work on that, because that's beyond the scope of what we can do here. So,
And you're getting denials on those other medications, is what you're saying.
Yes.
I know that.
But it's more about that 1 month clause in there.
Yeah. Well, the 1 month clause is limited to sedative hypnotics.
I think like what I can never pronounce that one. Those types are considered sedative hypnotics too, right?
They are, even though they act totally differently and are actually in a completely different drug class, because they got put in that category, they fall under that. The suvorexant and
Yeah.
so the dual orexin receptor antagonist, yeah.
So maybe we need to be more precise with our language there.
So what
That
I'm,
would be-
what I'm kind of seeing here is we'll table this. I will work with Dr. Henderson. For the unable to access CBTI, you need to have documented, we can look at the Sleep Society, and pick a few of those things. And then we can work with P&T to figure out if we need to change our wording about the 1 month. If they
Well, I
reports Suvorexant and those types of medicines.
I think there's good evidence that the 1 month is the part is okay. Maybe it's the sedative hypnotic that needs to be adjusted, but I don't know that we aren't gonna be able to move those drugs from one type of a medication into a different bucket. But you can talk with P&T.
It could be P&T can resolve it.
Yeah, we'll look at P&T and figure out what they think would work or not work. I'll work with Dr. Henderson with that whole conversation, and we'll work on wordsmithing the unable to access.
Okay.
Things we're going to work on while we are looking at this.
I guess I would also, I'm still struggling a little bit with this app book other non-provider option and the precedent that sets for other spaces. I guess, Ariel, I would be interested to know like what the evidence is for CBTI being delivered through those modalities as compared to like traditional in-office delivery models.
Okay, I will look to see if there's any evidence. I think Dr. Henderson quoted some things about the app, so I probably will call on you for that. I don't know. I believe when we looked at this a few years ago, there was evidence around the VA app, which is free. I don't know about books.
Maybe that's the part.
Books out there, but again, you have to be.
Yeah, maybe that's the part we look at.
To it and motivated and.
Okay.
Yeah, I don't think there is any evidence on the books. There's been studies on the online delivery and app delivery. I don't recall finding any evidence on book delivery.
Great, so that's something we can take back and look at closer, and we'll bring that back. So we're gonna table this insomnia discussion, then let's go back to hypersomnia, since we grouped them and now we're going to table half of it. So let's go back to the hypersomnia part that we discussed previously. I got it. Just let me get this done. So anybody willing to make a proposal? Let's go back and put up page 84 on the list.
Yeah.
Hypersomnia.
Please. So we all know what we're talking about.
This is Chris. I propose to accept the staff guideline as written.
I'll second.
Thank you. Jessica, can you roll call for approvals of accepting the staff recommendations as written on the board?
Brian Duty,
Yes.
Mary Beth Engrave,
Opposed?
Adrian Irwin,
Yes.
Max Kaiser,
Approve.
Sarah Love,
Approve.
Chris Pinzon,
Approve.
Katie Shable.
It's gone.
Oh, that's right. And Holly Jo Hodges.
You technically can, but
Does it pass with 4 votes?
it does not pass with 4 votes. 1, 2, 3, 4. We've got 5 votes.
No, we have, Mary Grave is opposed. We have
Brian,
4 ayes.
Adrian, Max, Sarah. It's 4.
Yeah, that's 4. It won't pass.
It's Mary. I did vote. Did you hear I did vote. Did you hear my vote?
Yes.
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 Yes, and Chris.
Okay, thank you.
Chris.
So Brian,
And 4
Adrian,
votes.
Max, Sarah, and Chris.
4 in favor, 1 opposed.
1, 2, 3, 4. No, 5 in favor.
No,
With Chris, Brian, Adrian, Max, Sarah, and Chris. That's 5.
Then I can abstain.
Yeah.
I'll abstain. Okay, so we need to go back because Max had left the room, we didn't have a quorum, and pick up, don't ever do that again.
Can't go back. Unfortunately, it wasn't urgent.
So, can we put back up where we were at with the
All the straightforward.
straightforward, please?
It was multiple things.
Okay, so I'll entertain a motion to approve the straightforward agenda.
So moved.
Brian, thank you.
Second.
Second, Max. We'll roll call for approval, please.
All right. Brian Duty,
Yes.
Mary Beth Angreve,
Opposed?
Adrian Irwin,
Approve.
Max Kaiser,
I should say I did review this, so I didn't miss something when I was out of the room. Approved.
Sarah Love,
Approve.
Chris Pinzon,
Approve.
Holly Jo Hodges.
Approved.
Okay, sounds like it passes.
Okay, so we'll go back now and pick up nitrous oxide. Thank you, Dr. Henderson. I think unless there's
Page
something
97.
Thank you.
something I don't know about, thank you so much for joining us. Appreciate it. Appreciate your help.
Thank you very much. Appreciate it. Bye.
All right, our next topic is nitrous oxide for non-labor indications. So nitrous oxide is known more commonly as laughing gas. It's used commonly for pain relief during dental procedures, but it's also used during anesthesia and other types of procedures. OHSU, Center for Women's Health, and Planned Parenthood, the Columbia and Willamette reached out and asked that we cover this for certain gynecologic procedures, that they're starting to offer this as a pain option for things like IUD insertion.
Page 97.
PNT, or I'm sorry, IND, other gynecologic procedures. And then OHA Medicaid also is asking us to clarify this. So use of nitrous oxide during dental procedures has a CDT code that's on various lines, so that seems to be the intent to cover. We have a guideline saying that we cover it for labor pain. It's being interpreted, that guideline is being interpreted to say we only cover it for labor pain, when I believe the intent when that was adopted in 2015, 2016 was that it was called out as it is used, it is appropriate, but not necessarily, you shouldn't use it for other things. So we did review this in 2015, 2016 as a coverage guidance, and it was found to be safe and effective for labor pain. As I mentioned, it's currently used, it's a very commonly used dental pain agent. Looking at the evidence, the CDC recommends some type of pain control for certain gynecologic procedures if available. There's a Cochrane review that it's effective for dental procedures. And it's also, there's another Cochrane review that's quite old, about 15 years old, that it's effective for colonoscopy. Submitted literature included an RCT comparing nitrous oxide to sort of the more common IV medications for minor gynecologic procedures, and it was found to be just as effective as like the midazolam type of procedures, but it had fewer side effects and a much faster recovery time, because this is typically out of your system within minutes after the gas is turned off versus a lot of the IV medications, which may take hours. And then another RCT looking at this for hysteroscopy also found that it was equivalent to oral sedation for pain management during these procedures. I couldn't find many written policies. Washington Medicaid does cover this for office procedures when the facility is equipped to handle patient safety. That should be pretty obvious. So in summary, nitrous oxide is safe. It's been used for years in dental procedures. It's being used more commonly for medical procedures now. The evidence is pretty limited, but it is a widespread practice, probably not being very studied at this point because it is in widespread use. But there is some evidence that it can reduce pain during gynecologic procedures. And HERC staff does not feel that the current guideline was intended to limit its use to labor pain, but rather just to call out that it could be used for labor pain. So the recommendation is to modify the current guideline to essentially say we cover this for labor pain, dental procedures, and medical procedures, And I do think we should keep a guideline because there is no specific CPT code or HCPCS codes for this other than the dental use. So if we keep a guideline, it will call out that we do cover this. And HSD is aware there's no billing code, and they are working on ways to allow people billing us for it to indicate that that's what they're billing us for. Questions?
So you just said there's no billing code except for dental procedures.
Correct. There's no specific billing code for nitrous oxide. But Medicaid is thinking about using the modifiers and doing a certain modifier so that the procedures, the facilities that want to do this can indicate that they were using it.
Yeah, it's just been used for years for lots of things, certainly for dental, but.
Yeah, and it, as long as you are qualified to respond to an emergency, I suppose you should be very safe.
Yep. Right. Thoughts, concerns?
I am happy to see this.
Hi, it's Mary. I have a question.
Yes, Mary.
So do we think there's not enough alternative options right now that we need to add this? And then how long would it take to get the fee schedule in place? And so for outpatient procedures, those are my two questions.
At least 2 outpatient providers in Oregon are requesting the use. And I think they're seeing it as, so if you do oral pain and anxiety medicine or IV pain and anxiety medicine, you typically have to have a lot of, recovery time, all of that, whereas nitrous oxide is out of your system really fast. They don't need to necessarily have a driver on the way home. They don't necessarily need to be there for a period of time for observation. And
Okay, Mary, what's your concern?
It's not a concern, it's just a question. Do we really not think we have enough options that we need to add? It's just not clear to me how much there is a need for this. So that's my question.
I would say there's a need and it's already being done and used. It's just not being reimbursed. That would be my interpretation. We used to use it in our ER, but I'm old.
yeah, and as for the billing question, Mary Beth, I know that they're working on that. It will be available at the speed of government.
That's a good answer. I like it. Thank you.
We used to set fractures in the ER with it. It's great. All right, any
Oh, I'm sorry. I need to do a friendly modification. I realize this is still limiting it to line 1, which is where labor pain is. We should probably make this a statement of intent.
or ancillary?
Or
Would it go with pain management?
Yeah,
I think
ancillary.
I think ancillary guideline note would be better because that's clear to all of us that use them.
Yes, and it's
What
an
that means.
anesthesia is an ancillary service.
Right, so I think that would be, nitrous oxide for pain control
Yes.
as ancillary.
I apologize for not catching that earlier, but I would make that friendly modification.
Thank you.
This is Chris. I would move to approve with the friendly modification.
I'll second.
Thank you. Moved and seconded. Let's go ahead and vote on that.
All right. Brian Duty,
Yes.
Mary Beth Engrave,
Opposed?
Adrian Irwin,
Approve.
Max Kaiser,
Approve.
Sarah Love,
Approve.
Chris Pinzon,
Approve.
Katie Shable.
Not here.
Oh, that's right. Holly Jo Hodges.
Approve.
All right.
Great, thank you.
Motion passes.
All right, so moving on to CBT for migraine headaches, and we do have testimony.
Page
when you're done
103.
presenting. Thank you. when you're done presenting, Ariel.
Of course, we can take testimony at that point. So I'm sure you're all aware what cognitive behavioral therapy is. It's a form of psychotherapy. Migraines are serious headaches. We currently cover migraines. We cover all types of therapies for them, medication, Botox injections, acupuncture, and biofeedback. This question came to us from Pharmacy and Therapeutics. They were looking at an HERC review and meta-analysis that was just published at the end of last year that examined the effectiveness of cognitive behavioral therapy as an alternative or an adjunct to medications for migraines, and they wondered if we wanted to consider that. We had a task force on migraines in 1997 that added biofeedback, relaxation training, and acupuncture. They added a couple of those. Acupuncture was actually added in 2011. Keynote Innovation was added in 2014, and then biofeedback was finally actually added in 2021 based on a VA evidence review. Currently, migraines are on line 407. Cognitive behavioral therapy is on a large variety of behavioral health lines. So ARC published a behavioral interventions for migraine prevention at the end of last year. They included 45 RCTs, although they did note that about 3/4 of them had a high risk of bias because they were small or did not report sufficient information for effect size calculations, and there was questions about the ability to detect potential benefit of treatment. So for CBT for adults, they had thought that it may reduce headache frequency by about 1 migraine a day per month. They noted that migraine disability did not meet their minimally clinically important difference. And then for quality of life related to migraines, they found inconsistent results, preventing them from making any conclusions. They found no real significant difference with biofeedback. They weren't sure about relaxation training. You may get some help with mindfulness-based therapy, and you may get some improvement in disability with education. So essentially, a lot of these things were not really terribly effective in their evidence review, and they noted that there were probably very few adverse events, although these weren't typically reported. A few years ago, Cochrane also did a systematic review on psychological therapies for migraines. They included 21 RCTs, and most of them compared cognitive behavioral therapy to either no treatment, routine care, or waiting lists. The overall evidence was noted to be very low quality. They found no evidence of effect of psychological interventions on migraine frequency or migraine days per month. They found no effect on migraine intensity or migraine medication usage. So essentially didn't find much effect for these. Looking at expert guidelines, the American Headache Society only addresses medications, and the European Consensus Statement also only addresses medications, and the ACP's guideline. The VA does cover CBT for migraines. Kaiser notes that it can be helpful for co-occurring depression or anxiety. So in summary, cognitive behavioral therapy for migraines was recently evaluated by 2 of our highly trusted evidence sources, ARC and Cochrane. ARC found that CBT may decrease migraine frequency by maybe 1 day per month, but did not affect disability or quality of life. Cochrane didn't find any evidence of effect of migraine frequency, medication usage, mood, disability, or quality of life. And neither study found significant adverse effects. The HERC staff conclude that CBT is safe, but has limited evidence of effectiveness. Patients who have both migraines and depression, anxiety, or another mental health disorder do have access to CBT. Staff is not recommending adding CBT to the migraine line at this time. If you do desire to add them, then the procedures for CBT codes could be added to the migraine line. If you desire, but the current staff recommendation is to make no change. Any questions before we hear our public testimony?
Anybody?
I see a hand up of one of our attendees, but I don't know if now is the right time.
Let's go ahead and take our public testimony first.
I didn't.
Lisa Cruz is here. She's a HERC member, but she's not attending. But let's take our testimony first. So based on, you have 3 minutes to testify. There's a progress bar showing behind you, which is not very helpful.
No, it's not. Really not.
So somebody has to give me the
Go,
2-minute warning.
Sure.
And I'll yell,
I mean,
Thank you.
Okay, there we go.
We'll give you the signal, and please stay a few minutes in case people have questions. But go ahead when you're ready. I'll start with your name and any conflicts of interest.
Okay, my name is Maria Cuadron. I don't know what my conflicts of interest would be, but I am a patient, and my daughter's a patient. I should be a patient. I'm so glad I'm here, given what I've been listening to, because CBT has really changed our lives. We accessed it through the migraine clinic at OHSU. My child is 15. I wish I just heard about this and came down because I felt like it was so important and so impactful to our lives. But I also know from the people that I met while doing this, who also parents and families, who have been on this path of getting relief and care for their children, that it has changed their lives as well. So that's why I'm here. My child has probably had migraines since she was a child. Funny enough, we went through all kinds of places. We've been on OHP, and being able to get here has changed everything. If I had more time, I would actually bring data. So when I was first at OHSU, we had about a 60% attendance rate at school because she was so impacted. We got our diagnosis. Shortly afterwards, we're able to meet with a CBT therapist who gave my child the tools to manage the fear that came with these headaches. I don't know if any of you have ever had a migraine, but they can go anywhere from you going blind and being in severe pain to just being in pain for a very long time. And when you have a child that is in pain, it is excruciating to watch them suffer. With the, I want to say, short period of time that we were there, and so many people that wanted access to this, we had enough skills to be able to move forward. Yes. Oh, thank you. So one of the things that I think is most important about this was that it gave us the strategies to identify and reduce the amount of migraines that she was having. In the last month, I've only gone to the school once to pick her up for a headache. She's been able to take medications that are heavy duty medications. Some of the side effects can cause blindness. You have to make the decision to do what's right for your child. But without the CBT, it would have been so hard to be able to be able to get her the treatment that she needed. So it's life-changing for me and everybody else that was there. Thank you for this opportunity. I really hope you reconsider. Yeah. It would be a shame.
Thank you.
Thank you.
I think, so did, you said, is Dr. Koussis on the line? Is there something that you wanted, I don't quite understand, kind of a little out of order here, but did she want to say something?
Yeah, Lisa, did you want to say something?
It's just
Am I-
There we go.
Am
Am I
Unmuted.
able to speak through? Yeah, okay, cool. No, I'm going to be testifying at the next topic, but I was told by staff that I should raise my hand once I join so they can find me and then eventually make me a co-host, I think is what happens when I'm testifying. So no, I'm not commenting on this topic. Thank you.
Okay.
Sorry, thank you. Sorry, Lisa. That's why I was confused. Now it makes all sense. I just wanted to point out that as it states here, that the CBT is, I'm just reading off the second paragraph, is a safe treatment strategy for migraines, has limited evidence of effectiveness. Patients that have both migraines and depression, anxiety, or other mental health diagnoses will already have access to CBT. So I just want to make sure that that's very clear, because I am sure I had a child with migraines. It causes depression and anxiety. And that is your avenue with your funded comorbid to get a CBT. Chris, you want to ask me a question about that?
No, I actually did not have my hand up. I agree. I think first I would like to thank Maria for coming to testify, and for, defending CBT as an effective option that was life-changing for them. And again, yeah, the access is there, and the impact on quality of life for folks with headaches, I think, will quite quickly go to those secondary conditions that will get them access to the CBT. I guess I wonder if where it's offered makes a difference. Like, what I heard was they gained access through it via a headache clinic at OHSU, but I don't think any clinic is limited to using these diagnostic codes because of their settings. So it's available to anyone, to any provider that would be able to address headaches is also going to be able to address any of these other issues that may be more behavioral or mental health related. Would you agree?
Specifically, most PCPs are well equipped
Yeah,
to
yeah. So
direct
I
care
think,
for that triad.
yeah,
In most mental health, even if you refer someone to a mental health practitioner for migraines, but they find there's coexisting anxiety or something, they can change the diagnosis that they're treating.
They can add a diagnosis that they find.
It
So
pairs with
may I ask a
adjustments.
question of Maria?
Yeah.
Maria, I'm just curious. I am a big believer in school-based health centers, and I'm wondering if that was one of the places that you explored and whether you had success there with someone able to access or direct you to these treatments through that option before you ended up at like OHSU specialty.
No, we had been given therapy, but never CBT therapy. We only actually got it through the migraine clinic. And I would say like the way in which it helped the most was sometimes even just being able to take a pill, because there's so many side effects, like walking someone through the process of medication was highly effective, I guess. Does that answer but no one had ever given us that. They did other things like talk therapy or, breathing or this or that, but it was really the CBT that nailed it. And I'm happy to also give you guys data. I just needed more time.
Yeah, well, I hope what you're hearing is that it is covered. And what I'm hearing is that you are a very strong advocate and maybe getting that out to some of the other folks where there's more pediatrics settings. So it doesn't take someone getting to a specialty. Well, you have our support, and I think it's
As I
sometimes our
definitely
implementation
understand.
isn't as effective as we'd like it. But folks like you can make that more common and known so that people know how to access it and that it is a covered benefit.
Right. That I understand.
Yeah.
Thank you.
Yeah, no, thank you for coming today.
Yeah, and Maria, if you do, you or your daughter have any problems accessing this, get in touch with HERC staff. We can help work with whatever part of the state agency or the CCO needs to know.
Appreciate it. Thank you.
This is Caitlin Green. I just had gotten an alert that I was asked to be unmuted. I don't know if I have an opportunity to say something. I'm a pediatric headache specialist, and I'm actually the doctor for Maria's daughter. So I'm very grateful for her to speaking today.
Yeah, we can.
I'm sorry, hang on, so, by protocol, this is out of order. So normally we have speakers, sign up and we are allowed, a certain time limitations. And we used the 3 minutes, so, I'm sorry, and so you are who again?
I'm sorry, I wasn't planning to speak. I had just gotten notified through the Zoom app that I was asked to be unmuted, so I didn't know if I was being asked to say something. I'm also hoping to make it in person to speak later this afternoon on this topic. This is Caitlin Green. I'm a pediatric headache specialist at OHSU Dornbecker.
Okay, but you're on the docket to speak at HERC this afternoon?
Holly Jo, I think we can hear.
Okay.
Be public testimony.
She did not register, so I think we need to move on for this morning. We've got a very full agenda. So thank you, Dr. Green. Sorry about the confusion there.
All right. So other questions, thoughts?
I was just noting it pairs with adjustment disorder too, which is.
Say that louder.
Yeah, it pairs with, CBT also pairs with adjustment disorder, which is some temporary, it's not the official more significant anxiety or depression diagnoses. So that can often be very appropriate for somebody who's experiencing something like we just heard.
Okay. So there's no recommendation for change.
So I'm gonna make sure that I understand. So CBT does currently pair with anxiety, depression, adjustment disorder, all of these. So patients who would have a combination of migraine headaches and these other conditions would have CBT covered. So really the expansion of scope that we are looking at is only patients who would have a singular diagnosis of migraines with none of these other paired conditions. And then looking at the evidence, I'm just summarizing to make sure I'm fully following, that the two Cochrane review and the ARC studies are specific for CBT with kind of monolithic migraines, and that is the place that there has limited evidence of effectiveness. Am I getting this decision correct?
That was my understanding.
Yep, that's my understanding.
Yes.
Ariel, did she nail that? I think she did.
I think so.
Yeah.
That's not good.
I think it's all right. That's the way I understand it. I think that's how everybody in the room understands it. Anybody online have a different thought? Okay, we're on the same page. You can make a motion of any kind.
I just wanted to make a note for Dr. Green. I hear that you're going to speak this afternoon. The other option would be to communicate with HERC staff. We can always bring this topic back if you're unable to join us this afternoon.
She's already signed up and planning to come this afternoon. I think it's fine. Okay.
Motion to approve as recommended.
Thank you. Max has given a motion to approve HERC staff recommendations as made.
Second.
Brian has seconded. We'll roll call.
All right. Brian Duty,
Aye.
Mary Beth Ungrove,
Opposed?
Adrian Irwin,
Aye.
Max Kaiser,
Approve.
Sarah Love,
Approve.
Chris Pinzon.
Opposed?
All right, and Holly Jo Hodges.
Approved.
Okay, I don't think it passes.
So
Five
1,
votes,
2,
yes.
3, 4, 5. Yeah, we have 5 yeses, so it does carry.
Okay.
Moving to lipomas, page 107.
Great. So the question is whether to add coverage for removal of lipomas. This comes to us from Dr. Seaton, who's a general surgeon in John Day, Oregon. Just for background, lipomas are benign fatty growths. They're frequently subcutaneous under the skin, and they may be removed for cosmetic reasons. However, they can be in deeper areas of the body. They can become quite large. They can interfere with joints or other parts of the function of the body, and they can cause pain. In those cases, they are considered for removal. So generally, the first step, if you have a lipoma that's large, rapidly growing, painful, or you have an unclear diagnosis, you do an ultrasound. Lipomas that are greater than 5 to 10 centimeters in size, and that range varies. Different guidelines have different size recommendations. Those that are deeper than the fascia, the subcutaneous fascia, painful, rapidly enlarging, or atypical features on ultrasound are frequently recommended for removal by various guidelines. In rare cases, these masses can actually be soft tissue malignancies, such as leiomyosarcomas or liposarcomas. This was actually came to us in a listening session in March. Dr. Dr. Seaton, who's a general surgeon, spoke about the inability to remove large or painful or functionally problematic lipomas. She recommended coverage for when they're greater than 3 centimeters or growing rapidly, and definitely over 10 centimeters that you need to remove it because of the higher risk of cancer in those very large ones. She argued that this is not cosmetic, and she also recommended that some of the very large ones do require advanced procedures, including flaps. This went out for public comment, and we received one public comment in support, and they added some additional procedure codes that were added to this summary. So we do have some of the those that appear in bones and joints are on a covered line, but generally they're on line 620, which is quite a bit below the funding line. The excisions are on multiple covered and non-covered lines. So there's not a lot of evidence. This is basically expert-based consensus. There was an expert consensus report published in 2022 that recommended orthopedic oncology referrals for masses that are below the fascia or greater than 5 centimeters in size or growing rapidly or painful. Another expert opinion published in 2018 is that most can be managed conservatively with observation, but those that are rapidly increasing in size, cosmetically unacceptable or symptomatic should be surgically removed. And then if greater than 5 centimeters or deep, should have a diagnostic MRI and should to help determine what the definitive treatment should be. And very deep lipomatous masses should be appropriately referred to a lipoma center. So the only private policy I could identify was Aetna's. They determined that excision is medically necessary if they are painful, inhibit a member's ability to perform ADLs because of their location in the body, especially those that have regular pressure on them. So Dr. Seaton, I reviewed her rationale and concerns. I ran this by our dermatology experts that have been helping us with the BUP process, and they also recommended. They looked at the recommendations. They agreed with the staff proposal, but recommended adding a clause about functional limitation that was subsequently added. So in summary, lipomas are typically benign, and they typically don't need excision. There is a small chance that what appears to be a lipoma could actually be a sarcoma, which is a cancer that requires treatment. Based on expert guidelines, lipomas should be removed when there are signs of possible malignancy, including large size, which is generally considered greater than 5 centimeters, rapid growth, or atypical appearance on imaging. And HERC staff recommended adding coverage of lipoma for lesions that have these characteristics. Additionally, lipomas that occur deeper than the subcutaneous tissue can result in organ dysfunction, obstruction, and pain, or they may need to be removed for definitive diagnosis. In most cases, the surgical excision can be done using the R code for the mass. You have an abdominal mass, you have a kidney mass, etc. But we do already cover 1 or 2 of these on lines with similar organ systems. And we recommend that similar other ones could be put on some organ system lines as well for the deeper lipomas. So the staff recommendation is that effective 10/1, we move the lipomatous mass ICD-10 codes. There's a very specific code, 17.72, which is genitourinary, and move that up to the cancer line. That would match it with the kidney lipoma. And then move the other benign lipomatous neoplasms to the premalignant derm lines that has all of the correct excision codes, and also keep on a lower line with a new guideline. The guideline would allow lipoma removal when at least one of the following is present. The lipoma is greater than 5 centimeters in size, or it's growing rapidly, or imaging is concerning for a non-benign lesion, or the lipoma causes functional problems that are documented in the medical record. And then effective 1/1/27, we would just need the typical change for the BUP guideline wording, and then there is a table of excisional codes that would be recommended. Questions for me, concerns?
So Ariel, I heard two different things here. You said, someone said they're particularly worrisome when they're over 10 centimeters and then that 10 got translated to 5. How'd that happen?
So there are multiple expert guidelines that I consulted, and the cutoff for where they consider something to be possibly a precancer or a cancer ranged from 3 to 10. So big range. So I took the middle recommendation, which was 5. Our expert, Dr. Seaton, the surgeon from John Day, recommended 3. There are some European guidelines that recommend 10, and then there are some that recommend 5. So.
Okay, I have one more question for Mike. And then I don't understand why we're adding this to a pre-malignant. These are benign lesions.
Right, mainly because it had all the
I
right
find that a
codes.
significant mischaracterization.
I mean, we could change the name. We could change, we could say dermatologic premalignant lesions and carcinoma in situ and symptomatic lipomas. They are benign, but this just had all of the right excision codes rather than creating a new line or.
Then yes, add wording for whatever, but these are not premalignant lesions.
Okay, so we could change the name of line 240 to be premalignant lesions, carcinoma in situ, and then symptomatic lipomas.
Thank you. Brian.
Well, I know you're sure that there's not regularity about this, but I guess I'm just curious what like rapidly growing means exactly. Is that?
It's rare, but they do.
That was also in expert guidelines. How could you determine if something was rapid or not?
Yeah.
I think that's more
Judgment call,
subjective.
Right?
Yeah, he's getting maybe.
We could remove that if you
No,
want.
I get it. I mean, like we have like with some of the renal masses, there are specific criteria about like a growth more than X number of millimeters per year or something like that. I doubt it's a significant number of cases. It just seems pretty subjective.
Yeah, and the kidney ones we already cover.
Right.
Yeah, that was another question. So are all the internal organ ones on other lines?
No, they're all still on 620, but I was told by Dr. Seaton that those are covered with our codes. So those would, like an abdominal mass code.
Okay. I've never denied one, so I didn't imagine that they were someplace that they just shouldn't be on this line, but they need to be on a covered line someplace else.
I can do that. I can look for, let me see. But the problem is they're intra-abdominal, intrathoracic. I mean, I guess I could try to find appropriate lines, spermatic cord, and then other sites. That one actually is only on the bone and joint line.
Technically, you won't know they're lipomas till you biopsy them. So I think I have some specific questions, but as a general question, like with these categories that are so varied, because I can think of 3 or 4 different categories of lipomas that I would regularly approve that aren't in this guideline. And some of the parts in the guideline, like rapidly growing, greater than 5 centimeters, non-benign on imaging, you shouldn't be diagnosing those as lipomas anyways, because it's a pathologic diagnosis. You can say it looks similar to, but unless you have a piece of it, it's, by my understanding, never diagnosed as a lipoma. So the first 2 and 3, if it's rapidly growing or non-benign on imaging, they should be putting in a code that it's a growing tumor, not that it's a lipoma. And I can think of a lot of other cases where I approve lipomas. So to me, this just seems like this is what we use exceptions for because there's so much variability in here. So other ones would be if it's a place that somebody has a functional, so it's not, you can't move a joint, but if it's on your temple, both if it's big enough because you can get skin thinning, or if it's anywhere where you can get skin thinning, but on the head, your subcutaneous tissue is so few if they really stick out, or if it's right here and the person wears glasses, like we take that off because they can't wear their glasses. So there's a lot of other exceptions I would include in this, and most of this guideline note, to me, shouldn't actually be changing anything, because you should be approving them if it's rapidly growing or doesn't look so unimaging. And then the other ones, to me, are exceptions. And I think why I'm asking that is I think there's a couple other similar categories we're talking about today, especially in dermatology. So I'm kind of philosophically thinking, how specific do we need to be in this new approach? And to me, this is not, that's kind of a middle ground. It's not specific enough. It's still going to miss a ton of things. So I'm still going to do a bunch of exceptions. So then kind of what's the point of having those types of guideline notes to me? I would leave this as an exceptional thing, but an exception thing. But I think it's useful to talk about it.
I would hear you arguing then to make no change maybe other than the one kidney one and leave everything else up to exceptions.
Yeah, because if they're really concerned about that it's a tumor, they should document that and why. And if it's really causing a functional problem, those are the exception ones. And I don't think we can write a guideline note that's going to cover everything that I'm necessarily going to approve. So then it kind of, what's the point if I capture 3 of the 10 reasons I might approve something? But I don't want to put all 10 because it's so specific. I'd have to think of every little spot where those can show up, right? So then,
Well, what's wrong with these 4?
I wouldn't leave. So the middle 2 don't make any sense to me because a lipoma is rapidly growing. It's not a lipoma unless you biopsied it. So that's the other one too. So if we say 5 centimeters, you can biopsy these things. There is a sampling error. I don't know what that is. Nobody's told me. Nobody seems to discuss biopsying these versus taking them out, and I'm not sure why, because you can biopsy them.
Well, yeah, a lot of the soft tissue tumors like this, they try not to, I think there's a high risk if you rupture the tumor capsule. I think they try
That's
to.
seeding? Okay, I've only seen the sampling error. I don't know about seeding. So that's what I'm wondering too. Yeah, because 5 centimeters, I see tons of people that don't take out 5 centimeters. If it's in a spot in your back, doesn't bother you, you're a side sleeper. There's lots of people that don't take out 5 centimeter ones, especially if it's not moving. And it can stay 5 centimeters for years. So suddenly if we're saying, let's cut out everything that's 5 centimeters, then we have to argue about what counts as a functional problem. I just don't see a lot of utility to it. I see it kind of increasing confusion. Because then if I read that, I go, okay, if it's thinning skin, like medically, I'm going to approve it. But that guideline note doesn't cover it. And we often deny things.
That's still an exception.
Right. We often deny things, though, using guideline notes and say, hey, we thought of all these criteria. This guideline note doesn't cover it. We often assume that HERC has looked at those scenarios and purposefully chose not to cover it. That can cause a complication confusion too. Like the nitrous oxide we just talked about, right? Everybody interpreted it as we can only use well, it said line 1. Take away the line 1 part. Everybody thought we couldn't use nitrous oxide for that. So then if they're looking at these and they say, well, they have 1 here and they have skin thinning, it doesn't bother their glasses. Am I allowed to take that out? Is that covered? Is it not? I just don't see a lot of value. And I think that, and for a couple other things we're going to talk about today. So conceptually, I think that might be a question we should answer is how, under this new paradigm, like how specific are we making? So we're adding 3 or 4 guidelines for really varied applications like this. And I'm wondering how specific we need to make these. What's the consideration? Where's the balance there?
Yeah, the counter argument we hear from providers and members is if it doesn't appear on the list, providers don't offer it to their patients, and then the patient does without it. They don't bother to ask for an exception. And so there's a.
Well, I think they might be missing diagnosis too.
That's the beyond
half of this is diagnosis, right?
And I see 12 of these a day.
Yeah, and half of these are diagnoses. So if it's rapidly growing, or they think it's large enough to be cancer, or it looks bad on an ultrasound, they should be saying this is a diagnostic excision. It's not a therapeutic, because they're worried that it's cancer. So there's 8 different ways we cover these. And we should approve them.
Yeah.
I don't even look at the diagnosis. If they get an ultrasound and it says, oh, this might be cancer, I'm like, I don't care what you wrote down on a piece of paper. If it might be cancer, you gotta take it out, you gotta check. So a lot of this kind of should be covered already, and it's a function of the list, and maybe that's education, but I'm not sure what the guideline note does.
Okay.
I'm also one person.
Hi, this is Mary.
Yes,
Oh, sorry,
Mary.
Max.
Yeah.
This is
Go ahead, Mary.
This is Mary. I support Max, and we're handling this the same way I support his comments.
And I can work with Dr. Seaton and find out which CCO is the one that mainly deals with John Day, and maybe explain to her how to do exceptions if that's what you guys want to do.
And maybe how diagnostic codes work too, because most of this should be diagnostic codes.
Lipomas are benign. A lot of people have them.
Sorry, I should say, that's the underlying too. We see requests for them existing a lot. And putting that line that's medically appropriate, I think would be hard to capture in a guideline note as well. I don't think I said that out loud. That's helpful.
So if folks are in agreement with Mary Beth and Max, we could approve staff recommendation 1, which is just a internal kind of lipoma, or we're not. We could not approve that. I don't know if it's been a problem. And then all of the rest, 2 to 5, would be no.
Any other discussion, thoughts?
I didn't defer to Max. He lives in the States more than I do. It seems very reasonable.
I'll entertain a motion of any kind. You can make one up.
Motion.
Max, do you move to approve only?
Don't put words in his mouth.
I was trying to.
Give him a minute.
Yeah, I would move to approve then option 1. I think it's reasonable if they're in organs and causing dysfunction. That's reasonable.
I can guarantee you those should be being approved now.
Right. Yeah. Do you have concerns about approving one? Because I'm fine just not doing that either. Because we have.
No, it's fine. I like it. You and
Yeah.
me, I like it to be as clear as possible on paper.
Okay.
So finish out what
Motion to
you're saying.
approve option 1 as proposed by staff.
Or no.
And do what with the rest?
Not approve the rest.
Thank you.
Oh, I didn't know I needed that part. Okay.
So on the table is a motion to approve number 1 as written and decline 2 through 5.
I'll second.
Just as a question, the packet only has 2 through 4, correct?
Well, yeah, we just did a friendly thing amendment.
I missed that.
Oh, to change the name because I didn't like the fact that they were calling them
but now it's
precancerous
moved.
Okay,
lesions.
yeah, 'cause I think I missed that.
Okay, so yeah, we changed it to symptomatic lipomas because they are not 100%. Or even,
But now it's moved.
99.
or even
But now it's-
1
but now it's
point,
removed.
but now it's removed because we're not doing anything. Okay, so there's a motion that's been seconded by Sarah, and so let's roll call vote. Jessica?
Roll call. Brian Duty,
Aye.
Mary Beth Engrev,
Approve.
Adrian Irwin,
Approve.
Max Kaiser,
Approve.
Sarah Love,
Approve.
Chris Pinzon,
Approve.
and Holly Jo Hodges.
Approve.
Motion passes unanimously.
Okay, point of clarification, it's 9:51. Shall we take a 10-minute break now and we'll come back?
We do have folks here for testifying about cervical spine manipulation. Are they okay with waiting?
You need to put your answer in the Q&A, please.
Yeah, otherwise we can push through, but I just was trying to.
I can offer a little bit of comment on that. I do believe that there is some wiggle room. For there's 3. I'm hoping that you have 3 experts for that topic at least.
Just 2, Lisa, just Dr. Daniels and Dr. Herzog.
Okay, and then I'm including myself as number 3. So okay, thank you. That's perfect.
They've both
Neither have let me know that they need to go very soon. So I think we're okay.
They both answered on the Q&A. They're all right.
Okay, thank you.
Okay, great. So let's take a 10-minute break. We'll come back and then we can go straight to the cervical spine manipulation and put the vitamin D second. Okay, thanks. 10 minutes.
All right, we'll get going here again.
All right, we're back live. So previous discussion items, let's skip to B, cervical spine manipulation. And Ariel, it's all yours, page 121.
So this should hopefully seem familiar to you all. So cervical spine manipulation is a procedure that's done either by a chiropractor or an osteopathic physician to realign the spine. We discussed this at our March meeting. The question at that time was whether to add cervical spine manipulation for tension headache as part of the BUP coverage process. The evidence that was reviewed at that time showed a small but clinically significant effect on headache and low risk of harms, and the staff recommendation had been to treat. The discussion at both VBS and HERC really centered around adverse effects. There were a lot of concerns about possible vertebral artery, which is the arteries that feed the brain in the back of the neck, possible dissection of those arteries, which is a very rare but known complication of these types of manipulation. And staff were directed to look into evidence of harms, as well as to have experts who are here today give any expert information and feedback about the harms versus the benefits of cervical spine manipulation. So currently, the CMT OMT procedures for cervical spine are on 3 covered lines for rheumatoid arthritis, one of the dysfunction lines in scoliosis and the back pain line, as well as the uncovered tension headaches and sprains and strains line. And just as a note, because of our current coding regimen, cervical and thoracic and lumbar are all the same code. So it would be impossible to determine which part of the spine is being manipulated just purely based on coding. So currently we have limits to cervical spine manipulation in the back guideline, that it's a limit of 30 combined with acupuncture and PT. And one of the requests that came up from this group and HERC at our last discussion of this was whether or not we should, if we do cover manipulation for cervicogenic headache, whether there should be visit limits similar to the back lines. So looking at evidence, there was an expert consensus guideline published in 2019 about chiropractic manipulation for patients with neck pain. They recommended 6 to 12 visits, follow up by evaluation for treatment effectiveness, as well as condition-specific evaluation, etc., after each encounter. So essentially, the chiropractic and osteopathic manipulation of the cervical spine, we already cover it for a variety of indications, and the rate of harms was previously reviewed and found to be low. If this group is really concerned about treatment for cervicogenic headache, you might want to consider the other places where this is a covered benefit to see if there was be any desire to remove coverage because of evidence of harm, although staff does not recommend that. The only changes to the staff recommendation that you saw in March is some minor guideline changes, which are in blue in the guideline, that would limit to 30 treatments a year, and it would also clarify that cervicogenic headache does not pair with massage or acupuncture, which would be in the same code grouping, and that was part of our discussion as well. So those are the only modifications that staff are bringing to you based on our March discussion. I'm happy to answer any questions, and I know we have several experts here to speak or to answer any questions.
Hi, this is Mary. I have questions. So I'm reading up to date on this issue right now. I'm going to read 2 paragraphs of it. A number of serious adverse events have been reported with spinal manipulations, and it goes through them, including vertebrovascular occlusion or dissection, carotid dissection. Vascular dissection may have significant consequences in patients with risk factors for dissection. Stroke or TIA, Ehlers-Danlos syndrome should avoid spinal manipulation, and obviously bleeding disorders, osteoporosis, Down syndrome, etc., aortic aneurysm history. And then here's an interesting stat. Let me get back down here. In a population-based case-controlled study, including patients younger than 45 with vertebrobasal or stroke, either due to dissection or occlusion, patients were 5 times more likely than the control group to have had a cervical chiropractic visit within the preceding week, and 3 or more cervical chiropractic visits within the prior month. So I'm just curious of the group's thoughts of that and any thoughts of how the benefit would outweigh that risk.
So I have a clarifying question for you, Mary Beth. If you're concerned about these complications, would you want us to remove coverage for all manipulation, or are you just concerned with it with cervicogenic headache?
I think this applies to all,
Okay.
if I'm understanding up to date. Yep. But maybe others have different thoughts, so I'd be curious to hear their thoughts from the group.
So I think maybe now we take some testimony and then we can wrap back around to this, Mary, and have some further discussion.
Sounds good.
Thank you. So I think we have 3 folks to testify. They each get 3 minutes each, and we're going to, we've got the timer there, and so what order are we going in?
We've got Dr. Daniels, I believe.
Dr. Daniels, you can now talk.
And Dr. Daniels, just
Yes.
for the record, if you could state your name, any organization that you're representing, and any conflicts of interest that are financial, not patient care.
Yes, and I had submitted slides a couple days ago. Are you able to bring those up?
Yes.
Yeah, we'll bring those up here.
Yes.
Also, good morning, everyone.
Thank you, good morning. We're pulling those slides up.
Yeah, while she's bringing that up, no conflicts of interest, not paid to be here as well. Should
All right,
I?
go ahead.
All right, and then do I just tell you when to change the slide? Is that how it works? Okay. So hi, everyone. I'm Dr. Clint Daniels. I'm the chiropractic section chief and resident director for VA Puget Sound Healthcare System. So I'm in charge of all the chiropractors in Western Washington that work in VA. And we take care of patients with tension type and migraine headache every day in our clinics. Also affiliated, still go back, please. I'm also affiliate assistant professor at University of Washington in Rehab Medicine, which is a research appointment. I'm chair of the Scientific Commission for Clinical Compass, which is a nonprofit that makes best practices for the chiropractic profession. And I serve as a committee member on the Washington State Health Technology Clinical Committee, which is sort of our state's equivalent of the HERC. And through that, I can say firsthand, I know how hard it is to make evidence-based coverage determinations. And I really appreciate the group's caution in the name of patient safety. That said, I think this is actually a pretty easy one. It's a topic that's been studied a lot, and I think the evidence is pretty clear. And that's what I'll go over in the next couple of slides. So next slide, please. So there have been more than 200 randomized controlled trials on cervical spine manipulation. Not one has ever identified a single study-related serious adverse event. And when we say serious adverse event, what we're really talking about, as Ms. Smits identified, is arterial dissection. That's the only real injury that's been sort of linked or loosely associated with spinal manipulation. So randomized controlled trials can be underpowered to detect rare adverse events. So when that's the case, the best evidence is case control studies and large observational population-based studies. And lots of these exist as well. Next slide, please. And they exist in lots of populations. We have them in Medicare data. Next slide. Private payer insurance data. Next slide. Academic hospital data. Next slide again. And the entire country of Canada. And really irrespective of population, all these studies really come to the same conclusion or very similar conclusions. Next slide. And that is that cervical arterial dissection is very rare. They have to look at millions of patient years worth of data to even find a signal in these associations. And the risk following seeing a chiropractor is essentially equivalent to the risk following seeing your primary care provider, which is to say it's likely not a major cause of arterial dissection. And I can dig into that more in questions if there are any at the end. But next slide. And I just want to leave you guys with, covering cervical spine manipulation for Oregonians with headaches is evidence-based, it is patient-centered, and it's also equitable. And thank you for the time.
All right, thank you very much. Why don't we go to the next presenter, please?
Dr. Herzog? If you could state your name and any conflicts of interest, and you can begin your testimony when you're ready.
Dr. Herzog, you can talk now.
Dr. Herzog, if you're in the virtual audience, if you could raise your hand, we can promote you and you can speak.
Can you request he unmute, Jessica, or have you already?
I have already.
You did already?
Yes.
So Dr. Herzog, you'll need to click the microphone button on Zoom in order to come off mute. There it is.
Thank you very much. Can you hear me?
Yes.
Yes, thank you.
Okay, so my name is Walter Herzog. I'm a professor of biomechanics and biomedical engineering at the University of Calgary in Canada. And I have done biomechanical chiropractic research for the past 40 years. Our group and we were the first to quantify forces exerted by chiropractors on patients. And our group was also the first and only one over the last 20 years to quantify the forces and deformations, that is the stresses and strains on vertebral arteries, so the crucial artery that we have been talking about during chiropractic neck manipulations. We have done multiple studies that were published with different approaches, different techniques, different equipment, different chiropractors, and different technical and student populations involved. And out of these many studies published over the past 20 years, there were really two main results that were consistent that I would like to emphasize here in this context. And the first one is that the elongations and deformations of the vertebral artery during chiropractic neck manipulations were always smaller by about 50% than those that a person can achieve by going to the end range of neck and head motion. For example, when you reverse your car out of a driveway, or when you look up at the stars at night. The second point that I wanted to make is that the vertebral arteries are attached to the cervical vertebra with slack. That is, during any head and neck movement that you do naturally during the day, including also chiropractic manipulation, the vertebral artery is actually never stretched. The tissue is never stretched. It's never deformed, but merely slack is taken up. And therefore, the overall conclusion that we have derived from these multiple studies was that vertebral arteries are not stretched or deformed during chiropractic manipulation, nor during any movement that you do during the day. So we know that there are no forces or stresses that are acting on the vertebral artery during spinal manipulation. Thus, it appears not possible to cause mechanical damage to the vertebral artery during chiropractic spinal manipulation to the cervical spine or the neck. Where there is no force on the tissue, there is no stress. Where there is no stress, there can be no damage, and therefore there cannot be stroke that is associated with vertebral artery dissection or other mechanical damage. Thank you.
Thank you. And I believe, Dr. Koussis, did you want to make a statement, or do you have any slides?
Good morning. I don't have any slides, but I will just quickly make a statement if you want to start the bar or however you want to do that for me.
The timer. Got it. Jason's got it. You're good to go. Thank you. Go ahead.
Okay. Good morning. Thank you for having me. My name is Lisa Kouzes. I'm a licensed chiropractic physician in Oregon and Washington. I serve as a commissioner on the HERC. And I'm just going to kind of jump down to my general opinion is that cervical artery dissection adverse events are very rare, and the best available evidence does not support a causal relationship with the chiropractic treatment. I would like to point out that the 2022 CDC clinical practice guidelines for prescribing opioids for the management of pain, recommendation number 2 has, quote, spinal manipulation for tension headache, end quote. I'd also like to direct your attention to the written testimonies by Dr. Bouchard and Wheaton, who are also leading experts in the world in this field. And I'm wondering if I could have again that citation from Mary Beth, because my understanding again is that when you make the control population your primary care, seeing a primary care physician, then it's relatively even as far as if you go to a chiropractor and go on to have a stroke, or go to a PCP and go on to a stroke, because there is an association with patients who are experiencing neck pain or headache, where it turns out to be an artery dissection. They seek care for that. So in that sense, there is an association with seeking chiropractic treatment and subsequently having a stroke. But as far as the causation component, there's not good evidence to support the causation when you look at the entirety of all of the studies that have been done. Thank you.
Yeah, this is Mary. So it's on Up to Date, and if you look at Up to Date under spinal manipulation, the references are there. I guess the other question that brings up, to your point, is if a patient presents with a headache and neck pain, and a diagnosis gets missed that they're having a dissection, that's a different issue, right? Like if you go to a provider and that's a misdiagnosis, then jumping ahead to spinal manipulations doesn't seem like appropriate treatment. So it might be warranted that the patient have an evaluation to ensure they're not having a catastrophic emergency before they get their spine manipulated. So that would be a huge concern.
Can I respond to that? I'm just kind of acting like a panel member. So that's definitely a valuable concern, and that has been looked at as well. Because it's quite rare, but headache and neck pain are quite common. And then the presentation of an artery dissection can be asymptomatic. It can have neck and headache pain. It may not present with the worst headache you've had, but chiropractic physicians are trained on looking for those red flags. And so we have the same, we do have a differential diagnosis process, orthopedic physical exam testing, neurologic testing. Some patients who have an artery dissection don't have neurological symptoms. And those kind of, to me, would be the hallmark of when it is obviously different from a regular headache, because there may not be sufficient occlusion of blood flow because there are collateral arteries on the other side. So my understanding is that chiropractors are not any worse at diagnosing these than general practitioners, because they are very rare, very difficult to diagnose early. And there's no orthopedic test that has any valuable sensitivity or specificity. And really the only way to do that is cervical, with contrast, like MRA or CTA. Any other questions, or for the other experts?
Thank you. Other questions for our presenters? We've got head shaking in the room. Online? Okay, I'll entertain discussion. Why'd y'all get quiet?
This is Chris. I'm so sorry I was late to return. I'm reading the staff recommendation right now. And I feel like the debate that we had last time was really on the topic of the cervicogenic headache and that migraine and tension headaches were still covered. And I'm trying to read through. So it's looking like there's a minor change. So we're still covering migraine and tension headaches. And then there's a guideline note for cervicogenic headaches, but it's referencing the code group of migraine and tension headaches again?
No, so currently, the cervicogenic, or the only type of headache that we've had found evidence for and have paired with chiropractic manipulation is cervicogenic headache. So the proposal, this is a benefit updates project. So this would put cervicogenic headache into sort of this general headache bucket that we've created, migraine and tension headaches, but the guideline would continue to clarify that it's only covered for cervicogenic headache.
So the debate is covered for neck pain as well, right?
Right, neck pain, back pain, arthritis, like the rheumatoid arthritis line has these codes. So other conditions it would be covered for, but not migraine or tension headache, which it's currently not covered for today.
So it's not mentioned, and that's why it's not covered, and the debate is whether to cover it.
So the debate is, as part of the benefit updates project, we have to cover cervicogenic headache, which is currently not covered. So the proposal had been to just put all of the headaches in one bucket, migraine, tension headaches. There's a variety of types of headaches. And then when cervicogenic headache is added to that group, the question was whether or not chiropractic manipulation should be added as a treatment, which it's currently paired with on its non-funded line. So if we move it, as the BUP project would move it to a funded line or funded code group, and the staff recommendation is to continue to cover neck manipulation. But since we're putting this in a large bucket that includes many other types of headaches, the guideline would clarify that it's only covered for the cervicogenic headache.
So it would not be covered for migraine and tension headaches.
Right, and that has never been the proposal. It's currently not covered for those. It's tension headache in 2025 list. Tension headache and cervicogenic headache are in the same non-funded line, but this guideline exists already. In that says that, it's the chiropractic manipulation is only in that uncovered group for cervicogenic headache. So
I see.
And that's because of where the evidence is that it's the cervicogenic headache that benefits from the manipulation.
So there's sufficient evidence to use it for cervicogenic headache, and the concerns were really about those rare risks. And so a lot of the clarification here is putting those risks in perspective with some of the other options that a client may have, or understanding that they may have already come with those risks before the treatment. And what we have support for is the training that chiropractors and primary care are all looking for those red flags before they initiate treatment. Am I understanding that correctly?
Yes. And that would be for manipulative treatment. So NSAIDs, whatever other therapies that would be covered for this are still covered.
Still covered. Okay.
Other thoughts?
Thank you.
And I guess it's just, the complication is pretty significant. And as I was sitting here, I was thinking, okay, it's like as a primary care doctor doing primary care, women's health, the things that you have to make sure you never miss. What came to my mind was ectopic pregnancy. Don't want to miss it. So it's kind of hard to then come back to this and say, well, this seems like something we don't ever want to miss because the misdiagnosis can be catastrophic. So I'm just trying to wrap my head around that. We can accept these
My interpretation from reading the literature and from hearing our testimony today is that there is a known relationship between neck pain and cervicogenic headache and the beginning of or an ongoing vertebral artery dissection. And so people might seek care because of their headache or their neck pain, either from their primary care doctor, a chiropractor, or other provider, and they subsequently go on to have a stroke at the same rate. So people who get manipulation have a risk of stroke if they're in that group, but it's not necessarily from the manipulation, it's from the reason that they sought care in the first place. Lisa, am I capturing that correctly?
That was what I got.
Yeah, I think so.
Dr. Herzog.
Yes.
Okay.
That's what they're saying the data support.
So Lisa, as a nurse, I don't do the same scope of work you guys do, obviously. What are those red flags? Could we just revisit that?
Well, I'm sorry, we have a really tight schedule today, so
okay.
I don't think that we can do a lot of physician education today.
Yeah, no, I hear you.
Okay, I appreciate that though. Sarah, any thoughts?
No, I don't have any thoughts, but I do have a patient I have to see in a few minutes. So if we want to vote on this and I'm needed for quorum, we should do that sooner rather than later.
Appreciate that. Other thoughts? Again, Adrian with the furrowed brow.
I think I'm okay. I'm just trying to reflect on what Mary keeps bringing up, and I'm trying to figure out how does that fit within the decision that's on the table today. But I'm not articulating a good question. Narrow question is not coming to my mind, so hence the giant furrowed brow.
Got it. I think we're struggling with a known significant complication of a process that presents in a way that it's difficult to diagnose.
Lisa, you have your hand up.
Oh, I can't see that. Okay.
Yeah. Could I make a quick comment about the up-to-date article?
Sure.
So I was able to look into that with the help of Dr. Daniels. The article that it references has the lead investigator is Dr. Whedon, who has provided public testimony on his opinion. So I think that is important to visit his comment. Thank you. And Dr. Whedon says that there's no support for causation.
Okay, thank you. That is helpful.
Hi, just to be clear, this is Mary. UpToDate is a database compendium that cites multiple sources. So appreciate there's a comment on one provider, but I would refer folks to that page. So it's not a single source, right? It's a database compendium that looks at all the evidence. So just to clarify that.
Mary, was the article spinal manipulation in the treatment of musculoskeletal pain? Is it that one or a different one?
Yes, correct. Uh-huh.
Okay, because under serious adverse events, the bottom of that first paragraph, it says no causal relationship between these rare events and prior spinal manipulative therapy has been conclusively proven or disproven. So it sounds like there's
there's a number of different studies cited. One thing that may be helpful is having a neurologist or a vascular surgeon come testify in this and give us their opinion.
Mary, can I clarify? I guess maybe, and I apologize, I missed the March meeting, maybe where this is coming from. Is your concern that we should not be covering this space because of the risks? Am I understanding that?
No, I don't know that it was Mary's
Correct.
concern. That was what was voiced.
I was asking a question about, that's the question I was asking, correct?
Okay, I
Yeah.
just wanna make sure that I'm
Just for clarification, yeah, in the March HERC meeting, this was brought up by a HERC member,
by her. Okay.
a spinal surgeon. Who's not here today.
Does she use fun?
No, she's in the
She's ortho.
orthopedic.
Which
So the motion or the recommendation that doesn't have a motion yet on the table is to proceed with the
There is no motion on the table. Right, there's the
Staff
recommendation. Yeah, okay, sorry. So-
I put forward the motion to approve the staff recommendation.
I have a motion to approve the staff recommendation as written on the screen,
Second.
seconded by Max. Discussion, clarification?
So the person who raised their concern in March, because I was not here at that meeting, is not somebody who is sitting in this room and has not continued to engage in that conversation.
Correct.
Is that correct? Okay,
Yes.
thank you. That is the piece of the puzzle I think was not getting it.
I apologize. Can you just, I'm getting a little confused with the conversation. So we're voting on whether to include, can you just reiterate what we're voting on?
So it's up on the staff recommendation, make a minor change to the approved placement guidelines from March 2025. We're adding into more of a code grouping, migraine and tension headaches. Again, this is BUP work, is that right?
Yes.
Yes.
So this is not something that will take effect October 1st. This is 1/1/2027. And then we're adjusting guideline note 218 to clarify 30 treatments a year to be consistent with our guideline notes 6 and 56 and other similar treatments to have a limit, and that cervicogenic headache does not pair with massage or acupuncture. Does that help?
Yes, thank you.
So we're not changing significantly current coverage.
No, we would be adding spinal manipulation for cervicogenic headache. That's medically necessary in 2027. So this is an expansion. Currently it's covered for neck pain, but not for cervicogenic headache, and this would be adding it for cervicogenic headache in 2027.
So technically it's paired with cervicogenic headache, but it's in a non-funded line. So.
Correct. So it's currently not covered.
Yes.
So Ariel, for your big bucket, you can still have the big bucket for headaches, but you're using the groups to designate these different kinds of headaches? Is that?
So the bucket
Or will it just be a guideline note?
And we would put a chiropractic in that bucket with the guidelines saying it's only for cervicogenic headache. If we don't want to do chiropractic, I mean, we would just not add the codes, and it would just, cervicogenic headache would just be in the bucket for typical office-based kind of treatments.
Okay, so we have a motion and a second. Is there more discussion?
So roll call a vote, please.
Go ahead, Jessica.
Ryan Duty,
Approved.
Mary Ann Greve.
Opposed?
All right. Adrian Irwin,
Approved.
Max Kaiser,
Approved.
Sarah Love.
Is absent. No.
Sarah had to drop.
Okay. Chris Pinzon
Approve.
and Holly Jo Hodges.
Opposed.
That's 4 yeses.
So we have 4 yeses and we
Two
have
noes.
2 noes, and we have 6 members present, so the motion carries.
Back to vitamin D.
Yeah, so we got vitamin D.
Page
in our last
114.
All right, thank you to our folks that presented.
So just to remind you all, we discussed this at our March meeting, or I'm sorry, at our May meeting. Vitamin D testing is currently limited to certain lines, but those lines have multiple diagnoses. And there was a question about whether we should clarify which diagnoses we actually want to pair with vitamin D testing. The Oregon Health Leadership Council came up with recommendations in 2019, saying that vitamin D testing was an overutilized service leading to healthcare waste, and recommended cutting back on the number of types of diagnoses that should be covered. And this agrees with various specialty societies, private payers, and Medicare coverage. We discussed this at our May meeting. At that time, there were questions about whether we should be covering vitamin D testing for additional indications that were not specifically listed. And the specifics that were brought up were particularly around orthopedic surgery, where you're working on bones. And currently it's sort of we heard testimony that it's standard of care in the orthopedics world to do this testing and to increase people's vitamin D levels prior to elective orthopedic surgery. HERC staff was also directed to see if there was any updated evidence since the OHLC's 2019 review, to see if there are any other evidence for different conditions or other ways of testing for vitamin D. So the USPSTF has updated their evidence review. It was published in 2021 and looking at 46 studies. And they found that vitamin D testing was not associated with any changes in mortality, fractures, diabetes, cardiovascular disease, cancer, depression, or basically anything. And they were inconclusive about the effects of treatment. So there's testing, and then what do you do with the tests? So looking at treatment, they were inconclusive about the treatment's effects on any physical functioning metrics. So looking at mental health disorders, there was a systematic review in 2021 that did not find any high-quality studies that assessed outcomes other than depression. And interestingly enough, only people who had high vitamin D levels benefited from supplementation. And that was also found in another meta-analysis in 2024. So essentially, there is a large body of literature, which I did not abstract for you all, that shows that low vitamin D is associated with depression. So this is the next step. If the low vitamin D level causes the depression, presumably supplementing with vitamin D to a normal vitamin D level should improve your depression. And that actually has not been shown to be the case. And that's what these couple of meta-analyses in 2024 and 2023 have shown. Similarly, for psychosis, in supplementing people with low vitamin D did not result in any improvement in first psychosis episode further outcomes. Looking specifically for preoperative supplementation, there was one systematic review of RCTs published in 2023 that noted no difference in overall mortality with supplementation, heterogeneous findings on length of hospital stay, didn't really see to have much overall benefit. And then the best I could find for the orthopedic specific literature was a systematic review from 2022 looking at vitamin D supplementation on total hip and knee arthroplasty, which do tend to be elective orthopedic procedures. They did find a statistically significant improvement in certain ratios after up to 48 hours after surgery, but nothing in sort of patient-specific things like rates of falls or osteoarthritis index. They did note that there may not be adequately powered studies to show a benefit. Other payer policies have essentially the same limitations that are recommended by the Oregon Health Leadership Council. So the basic gist of this is that vitamin D testing is a very common test, and it seemed to be a source of healthcare waste. Looking at the newer literature, there is a large body of literature relating vitamin D levels to bad things, depression, fractures, etc. But the studies don't actually show that supplementation improves any of these outcomes. And so it may be that that vitamin D may be a measure for something else, poor diet, lack of exercise, something else. That it's not necessarily the low vitamin D that's causing any of the adverse outcomes because supplementing doesn't help. So based on this updated evidence review, staff continue to make the same recommendation that you saw at our last meeting, which would be to have an extensive guideline sort of outlining the specific diagnosis codes that we would want paired, and these are the ones that have been shown to have some effect of supplementation, or they're just related to calcium and vitamin D metabolism. Questions for me?
This is Chris. It's more of a implementation question, I guess, since it's very limited what would be covered. What I'm seeing, and a lot of the discussion we had before was because it wouldn't change the treatment plan. You would still probably give people vitamin D supplementation. And so then would the documentation to get the test covered be that you really have to trial vitamin B supplementation first and then check the levels because they've already been on vitamin D to see if it's effective versus doing it preemptively just as a preventative screen.
The evidence, especially from the U.S. Preventive Services Task Force, is that as a screening test, it doesn't
Yeah.
prevent anything.
Yeah.
The conditions that are currently recommended to do the testing are things that really affect calcium metabolism. So a lot of the endocrine disorders or kidney disease, things where vitamin D and calcium, you need to know the levels. And sometimes it's actually you need to make sure the vitamin D level is not too high. And then things like clinical, it's very, very rare in this country to see rickets, which is extreme vitamin D deficiency. If you did see some clinical pictures like that, then it would be important to know the level so that you could adequately supplement somebody.
And there's really not sufficient data. It's like a secondary, because we think of it always as like a measure with fatigue, but really it's not the root cause. And so I'm seeing like none of the behavioral aspects of the symptoms were supported by good evidence.
Right. That was my reading of the literature, was that it's associated with many things, but there may be another thing that is actually kind of coexisting. So it causes low vitamin D and causes the problem.
Yeah. Thank you.
Thank you, Ariel, for doing this work. I appreciate it. Other thoughts, comments? Can you go up, please? So we have a guideline note. I'm sorry, the other direction.
Keep in 2027?
Yeah, so that's the guideline note that would be effective 10/1, and this is the BUP work that would be done for 1/1/27, correct?
Yes. So, what can we say? New code group.
Okay, got it. So back up to the.
And there's one alternative, delete guidelines.
Yeah.
2027.
I don't think that's hugely important. So basically we'd be making a new code grouping where it's only paired with certain things. So the guideline may become moot, but I don't think that's a huge decision point at this point.
So in making this guideline note, the reason these things are being called out is because currently vitamin D pairs on a jillion lines with a jillion.
Right. Yeah,
things.
some of the medical directors of the CCOs were very interested in having this clarification.
So Ariel, just to clarify, the medical directors for the CCOs are in favor of doing this?
Oh, yes, very much so.
Again, consistent with the OHLC and all of your best practices, you're choosing wisely.
Yep.
For the last decade.
I just know lots of physicians that are going to be very upset about this change. And so I'm trying to figure out if this is the hill that the CCO medical directors like want to die on.
It's already being like in OHSU in the EMR, if you order a vitamin D test, you have to go jump through a bunch of screens.
Yeah, you can't do it really anymore at HSU.
Yeah, you have
Just
to
because
have
of
very
choosing
specific
wisely and they've
diagnosis.
used EMR to get at those things. So it's not a secret.
They're also not.
It is
even- Go for it.
No, I hear you, Adrian. I think it's going to change the way people practice, and I'm just thinking about how will it impact patients and how is that going to get communicated to patients so that they still feel like their needs are being addressed. And for me, what I come back to is that it's not going to change their treatment plan. Like they're still gonna, there's not very many harms. There are certain situations, but I feel like the care is still going to happen. It's just the testing won't.
Chris, I actually think we're on the lagging edge of this. Medicare has been extremely strict about this for the last 5 years, and most private payers are. So I think most clinicians are aware.
Thank you. That helps give
Yeah,
context.
if you're primary care and you picked up a journal in the last 5 years, you should be aware.
There's question as to what is a normal level too. So even if you're checking it, it's kind of debated, and it's fat soluble, so you can overdose. I mean, you got to take a lot. So really, you shouldn't be super supplementing without checking. So that I think would affect treatment if you're not checking. Hopefully.
But at that point, you'd have a reason, right? So it's just like it's when I think about the public part, what I'm seeing is the screening's not effective. So we're trying to narrow it down to be more specific to what it's actually useful for.
Yeah. So this is what's in front of us.
So we need a motion to approve the staff recommendation.
Thank you.
Because we didn't do it last time, right? Okay, so a motion to approve the staff recommendation.
I'll second.
Seconded by Brian and by Chris. Roll call, please, for the vote.
Brian Duty,
Aye.
Mary Beth Engrave,
Excuse me, approve.
Adrian.
I'm sorry, we couldn't hear you, Mary Beth?
Approve.
Approve. Okay, if you could say yes or no, we're having a little trouble with your audio, just to make it sure we get your vote right. I think we got the yes.
Absolutely.
Adrian Irwin,
Yes.
Max Kaiser,
Yes.
and Sarah Love will be absent until 11:30. Chris Pinzon.
Yes.
And Holly Jo Hodges.
Yes.
It's unanimous.
Thank you. Okay, Ariel, anal fissures.
Okay, we have to get through anal fissures. This thing has been on our agenda for the last 4 meetings.
I think it's a hemorrhoid.
So
Page 126.
So we actually discussed this at our March meeting. Most of you all generally agreed with the staff recommendations, but there were quite a few questions raised, mostly about the availability of medications and other things that kind of step therapy in the proposed guideline. So just as a review, anal fissures are small breaks in the sensitive, kind of delicate skin around the anal opening. Acute anal fissures are generally treated with stool softeners, sitz baths, conservative therapy. If they become chronic, which is more than 6 weeks or so, they can be treated with topical nitroglycerin or topical calcium channel blockers. There's also Botox injections as well as surgeries. Since the March meeting, staff have consulted with our PNT colleagues. There is a topical nitroglycerin that's available for OHP patients. The calcium channel blocker would have to be compounded, which is more difficult for OHP to cover. But we do have at least one topical agent that we have access to. And so staff changed the proposed guideline to just include topical medications when available and not contraindicated. Obviously, topical nitroglycerin can be contraindicated in certain vascular, heart disease folks, etc. So currently they are acute anal fissures are on line 559 and chronic are on 519. the procedures that the surgical procedures may are currently sometimes on lines like anal fistula or congenital disorders of the GI tract or rectal prolapse. They're also on these uncovered lines. We currently have a guideline for chronic anal fissures, which again is on an unfunded line, and there is coverage there is pairing with chemodenervation with botulinum toxin, but again, a non-funded line. So our PNT colleagues at our request did an evidence review on the topical therapies and found that they have a lower non-statistically significant rate of some healing, some rare side effects. The American Society of Colorectal Surgeons suggests that lateral internal sphincterotomy, topical vasodilators, and botulinum toxins are all first-line therapy with moderate to high-quality evidence. And then the PNT review didn't find specific evidence for or against any particular topical therapy. And they did note that healing rates with the conservative therapy that we talked about, such as anti-constipation medications, etc., is nearly 100% when symptom duration is under a month. So that would be the acute phase, but closer to about 30% at 6 months. And similar rates of healing with topical nitroglycerin and calcium channel blockers compared to Botox. Although they did note compliance with topical agents can be problematic. And they looked at nitroglycerin and said costs were reasonable, and there's a rebate, et cetera, so we are allowed to cover them. I reached out to Dr. Herzog, who and Dr. Pedraza, who are the colorectal surgeons who have assisted with this in the past. They agreed with the staff recommendation. So the staff summary is that acute anal fissures is effectively treated with conservative therapy, giving people fiber supplements, telling them to increase their water, maybe using a topical medication, sitz baths, etc. So we recommend that we do not have surgical or denervation procedures for acute anal fissures, but they should be covered for chronic. So treatment of chronic anal fissures still involves the bulking agents, sitz baths, topical agents, etc. Both of our experts recommended an 8-week trial of conservative treatment before moving on to botulinum toxin injection or surgery. Chronic anal fissure is effectively treated with surgery and chemodenervation based on both evidence and expert recommendation, and it is covered by all private payers surveyed. This can be a painful and debilitating condition. So the recommendation is to move chronic anal fissures to the anal fistula line effective 10/1/25, and then that would become a code grouping with the BUP change. And then we would also change the line, the chemodenervation guideline would still apply, but we would have it would move into the funded region in that guideline, so it would be available. So effective 10/1/25, we would rename anal fistula to anal fistula and anal fissure. We would add acute and chronic anal fissure diagnoses to that line. We would add the chemodenervation CPT code, and then we would modify the current chronic anal fissure guideline. As you see in front of you, it would basically, you'd have to have 6 weeks of conservative therapy, defined as fiber intake, fluid intake, etc., bulking agents, and topical medicines. And one or more of the following, or the presence of pectinosis or fissures that have previously healed but have recurred 3 or more times. And then that would allow surgical availability. And then the chemodenervation, instead of on line 519, it would move to 391 with the same wording, essentially. Except for we would also add in there that you need to document conservative therapy for 6 weeks or longer. Or the fissures have to be documented to have lasted 6 weeks or longer.
So Ariel,
Oh, go ahead.
So you can do conservative treatment for up to 6 weeks and then get surgery, or you can wait 6 weeks and get Botox injections?
We could do 6 weeks. We could kind of do the same wording. I just realized that too as well, Max. We could put in wording, persist or progress in spite of 6 weeks of conservative treatment, defined as basically the same wording from the surgical guideline.
Okay, so then we'd have it, you have to fail 6 weeks of conservative treatment, and then you can either have Botox or surgery.
Right.
I guess I'm struggling with that too, because the Botox had similar efficacy. I assume it's actually probably a little more expensive because you said costs were the same, but I'm not sure, I don't know if office costs and admin costs were part of that. And it's also more invasive than a topical cream. So I'm wondering if we should have that and then surgery? So conservative topicals, that doesn't work, Botox, if that doesn't work, surgery. That's usually how we would step things, right?
I think that it's just, I don't know what the recommend. I don't know if anyone has actually done like should you do Botox before surgery? I think they're just different options.
But the Botox has similar efficacy to the topicals, right?
Yes.
So then I guess I'm
Oh, I
having
see what you're
trouble.
saying. Botox has similar efficacy to the topicals, not to surgery.
Right, but I also wouldn't want to skip the conservatives because I assume Botox is at least a little more expensive and it's more invasive
It's
for
definitely
sure.
more invasive and a lot more side effects.
Right, so I'd want to have it step, but then where does it fall versus surgery? That's what I'm struggling with. Well, maybe. I guess I'd want to know if Botox is effective after topical treatment, because if there is some step there, I would rather have them get Botox than surgery. It's less invasive than surgery. But if it doesn't have any more benefit, why are we throwing it in there? I guess I'm just a little confused about that step therapy there.
Ariel, can you address that at all? So Botox is more effective than topicals, but not equally as effective as surgery, or it's as effective as topicals?
It's as effective.
It's as effective, okay.
That was what I heard.
Okay.
Yeah, so I don't know if I can answer.
My God, Max, if we don't get this approved today.
I have a comment. This is Mary.
The American College of Rectal Surgeons, they actually call topical vasodilators and botulinum toxin and actually surgery are all first line. So apparently somewhat comparable.
No.
I guess I just want to make sure that Botox injections are reasonable second line. It's like, why is it even in there?
Hi, this is Mary. Can I add a comment?
Yeah.
Hi.
Yes, please.
I don't want to oversimplify this, but first of all, I trust HERC completely. And second of all, I just don't think people are seeking out either one of these treatments. I don't think it's anal fissure seeking behavior, right? I just don't think this is a highly sought after procedure. So I oversimplify things. I will be the first to say, but this is a slam dunk to me. No one's trying to get this. I would just approve this one.
Okay.
That's just my thought, though. I'm happy to hear other thoughts on this.
Essentially, with they're all equal efficacy, we just have Botox and surgery as second line because they're more invasive.
More invasive.
Logic.
And
Okay.
if you can just fix somebody with some Miralax and water, that's great.
Yeah. I'm just trying to figure out that path because it kind of didn't make a ton of sense. And for topicals, I think you said there was trouble with compliance. Is that just the area of the body and doing it consistently, or they have bad reactions or something?
I mean, nitroglycerin might make you lightheaded, give you a headache. I mean, I'm just thinking
Get
of
that
all
much?
known complications.
Some
And
people
if you
do.
can't get them the calcium channel blockers because they're
Okay.
only pounded, then.
Okay, doesn't get absorbed that much. Okay, thanks.
Okay, barring any further discussion, Mary, do I hear a motion on the table?
Yes, move to approve, please.
Because I just have an administrative comment.
Okay, Okay,
For the bottom where it's code line group 391, I think you meant to repeat the same statement from above, but instead of 6 weeks, it looks like it's 8 weeks. I think it's, is it a typo or did I miss something?
The 8 weeks is struck.
it's, well,
Oh, okay,
on
I'm
this
looking.
document,
Okay. Yeah, right. On the top, it's struck to 6, but if you look farther
Scroll down.
down,
The botulinum, it has to persist.
when it's in the other, when it's under the chemo denervation section, it's still as 8.
What page?
Oh, it changed. Okay, I'm sorry. I'm looking at it. I downloaded the document. My bad.
should be, I think they should be the same, but we'll check, make sure they're all consistent.
This may
We'll
be
make sure that that it's all consistent.
Last meeting material.
Yeah, I see it. It's in blue now. Thank you. On your
I
copy.
have the right wording
Thank you.
in what's going to be in the BUP, and we will make sure that it is consistent. I apologize. I just realized that I see where you're confused. In the BUP version, it has older wording.
Oh,
So ignore the BUP version. The BUP version will be the same, except for medically necessary rather than included on the line as what you're approving for 10-125.
Great. Okay.
Good catch, Chris. Thank you.
Can I move?
Thank you. So
Can I move to approve the changes?
we already have a motion on the table
Oh.
that I think we can just add a friendly amendment to wordsmith them. Can we do that? And so we have a motion on the table. You can second that.
Yeah, I second.
Great. Roll call this one, please.
Amendment.
Yeah.
Thank you for all your work, Ariel.
Brian Duty,
Aye.
Mary Beth Engrav,
Yes.
Adrienne Irwin,
Yes.
Max Kaiser,
Yes.
Sarah Love will be gone until 11:30. Chris
No,
Pinzon.
I'm here. I'm back.
Sarah's
Oh,
back.
she's back? Okay, Sarah Love.
Yeah, I'm just going to abstain.
Okay. Chris Pinzon,
Yes.
and Holly Jo Hodges.
Yes.
Motion passes.
Excellent. Let's move on. All right, Ariel, ENT BUP. Looks like we're on page 137.
Yeah, so we have a whole host of ENT issues coming your direction. The first one is tympanostomy tubes. Those are the little tubes that go in your ear when you have multiple ear infections. They're PE is pressure equalization tubes. They're also known as tympanostomy tubes. And we currently cover these for some indications, but they are below the line for other indications. We have reviewed this many times. Currently, chronic otitis media, which is when you have fluid in the inner ear lasting more than 3 months, it is the first line below the funding line. And we have made many workarounds to get ear tubes, including having acute recurrent otitis media being covered for it. And according to our ENT experts, there's a lot of kids in Oregon that have recurrent acute otitis media compared to the rest of the United States. But anyway, so we actually discussed this briefly at the EBGS meeting in April. This was on their agenda. Moved to your agenda because their agenda is way over full this month. And they didn't make any decisions. They didn't actually look at the key topics. Their main concern is that they approved the staff recommendation in concept, but they had some concerns about the wording of the guideline, and staff were asked to work more closely with, because the recommendation was to merge all of the guidelines that have PE tubes in them into sort of one master guideline, and it was noted that it wasn't actually effectively merged. So staff have been reworking that. And we have worked with the CCO medical directors and looked at the 2022 ENT guidelines for PE tube placement to kind of make sure that we were consistent and doing what the CCOs are kind of doing already. So currently PE tubes are on acute mastoiditis, hearing loss lines, cholesteatoma, which is a mass of the inner ear, as well as acute and chronic otitis media. So the hearing loss, so PE tubes are not actually a treatment for hearing loss. They are a treatment for hearing loss resulting from fluid in the ear, which is chronic otitis media. So that was one of our workarounds for the fact that we weren't covering chronic otitis media, is moving these tubes to the hearing loss lines. We currently have a guideline for acute otitis and a guideline for chronic otitis media. We worked with Dr. Peggy Kelly and Dr. Sarah Yang, who are pediatric and adult ENTs on this. There is an ENT guideline from 2022, and they recommend the use in at various points, depending on how long the fluid has been present and how many episodes of acute otitis media. So in summary, staff are recommending that we remove PE tubes and adenoidectomy from the hearing loss coding groups. This isn't actually a treatment for hearing loss. That should be like hearing aids and cochlear implants and those types of things. These are treatments for masses or fluid in the inner ear. So they should be available for chronic otitis media, and even when there's no hearing loss. I'm sorry, I'm hearing someone speaking. Is that just someone that not muted? Okay. So, and we don't think there's really going to be much impact in making the PE tubes available for chronic otitis media, because it sounds like there's a lot of kids getting this for acute recurrent, which is really difficult to determine if it's acute recurrent or chronic. So combining acute recurrent and chronic otitis media into a single code grouping with PE tubes and adenoidectomy, and merge the two guidelines. So what it would look like, there'd be a new code grouping, PE tubes, adenoidectomy, tympanoplasty, and we would attach what is currently guideline note 29, but highly modified. So it would basically say that PE tubes are medically necessary for recurrent acute otitis media with essentially the same criteria that's in the current guideline note 29. And then chronic otitis media with a documented fusion of 3 months or longer in children up to and including age 7. And there's wording in purple here, and this is my wanting to discuss this with you. There was a question about whether we want to clarify that children means under age 21 who are at high risk. And of note, tympanostomy tubes are not medically necessary for children age 8 and older and adults due to lack of impact on language acquisition. So that was another thing that we discussed at EBGS, is why do we not cover this for people over age 7 unless you do want to increase it to age 21? And that's because of the impact on language acquisition. And then the definition of high risk, this is from the ENT guidelines, and our guidelines are just kind of broken out into line instead of just kind of the big long run-on sentence that was currently there. So it involves craniofacial anomalies or other developmental or sensory issues. We recommend formal audiometry. And then if you're not at risk for language delay, and you should just keep re-examining them. But if you start to have hearing loss more than 25 decibels, or otitis media for more than, anyway, if you meet the criteria above, then you would get the tubes. If you're not really having any hearing loss, you can just continue to observe. And then adenoidectomy is medically necessary at the time of tympanostomy tube insertion for children under age 4 with symptoms directly related to adenoids, or in children ages 4 and older. And then you can remove the tubes when billed with a certain code. Any questions about this big mishmash?
Was the age 7, was that inferred from when language acquisition happens? Because I couldn't find it in the guideline.
No, so the current guideline says age 7, and we would either need to increase that to age 21 to match EPSDT, or we would have to put in a note, the note about it not being covered because of the impact on language acquisition. So
right, sorry, I meant I couldn't find the age 7 about language acquisition in the ENT specialty guideline though.
No, that was ours. That
okay.
is nobody else's.
And we invented it because of when language acquisition happens? Okay.
Before me even.
I would just be, okay, I would be concerned that under EPSDT, we're often held to specialty guidelines more than our own guideline notes. So
Okay.
just ease of use, I would like them to line up.
Okay, so that would be the purple wording under age 21 instead of under age 7, and we wouldn't have the note wording.
Yeah, there's still a little bit of gray area because the ENT guidelines essentially say if you have chronics over 3 months and a symptom directly related to that, you can do, they say may do surgery, so they don't require it, but there'd still be a little bit of difference or slop there. But yeah, I'd rather have it align more.
Okay. So what that would do, folks, instead of saying up to and including age 7, it would say under age 21 who are at high risk, and then there would be the note that's in purple would not show up.
I'm gonna go ahead and I'll do that now.
Do we still need to leave why it's not covered in adults?
We could.
That
Not
part
that
of
it's
purple.
necessary in adults.
I think it helps. Yeah, I think it helps to just make it explicit because it's inferred, but I think it can get confusing if it's not explicit.
Okay.
So I guess I'm a little worried about it still if we're going to MedNec and we made up that it's not based on any other guidelines, research information. But the ENTs didn't push back on non-coverage for adults with chronic otitis media? Did they realize it wasn't covered? That's what I'm wondering.
I think if they had to stratify the need, they would say children first, like they would
Sure.
go back to the kids.
Sure.
I think there was some concern about formation of cholesteatomas in adults. But it's much less of an issue with adults. So they didn't seem to really feel that was a big issue.
Okay. I've seen some. Yeah, I've seen some is why I'm asking. Okay.
And otherwise, do you think the wording is okay in terms of clarity?
Yeah, we looked at it like 3 times. So yes. Yeah.
The more the merrier.
There's a lot there, it's confusing, and there's a lot of recommendations of making sure it covers it all.
And this is all effective 27.
Yes.
This won't be an update to guideline note 29 for 10/1/25?
No, we would have to do a huge amount of code moving around.
Because of combining them too.
Oh, because I
We're
really just,
smushing these two.
yeah.
If you want, I can look at what it would take to implement this in 10/1/25 and bring that in August.
I would really love that. I just really like the language in B. The coverage that just that little bit of clarity is super helpful. You wouldn't believe how many adults they want.
Yeah, so what I can do, we would have to do a whole bunch, we could either, what we could do, the most simple way we could do that would be just change the guideline, have it be covered and uncovered still, so that would almost be more exception territory for you. I could work on moving codes, and then we would have the chronic otitis media line with like weird no codes, but we've done that before.
I mean, instead of smushing it, could you just update, I can't remember what guideline it is.
29.
29/51.
Oh, aren't there 2 though? Didn't we smush
And
it?
51.
Whichever one it is, just update the language without actually smushing the 2 guideline notes together and changing lines and all that.
So this is a smushed guideline. We would have to modify the 2 existing guidelines, and then we could attach it to the 2, the above the line and below the line lines. That would be the simplest way. It wouldn't add coverage, it would just hopefully add clarity.
Right, I was thinking that might be simpler. And still,
If you could could indulge me, I can just bring that as like a consent item in August or a quick discussion item, just to make sure I get all the different pieces correct.
Yeah.
So do we want to take this piece by itself and vote on it?
Yeah, this would be the approval for 2027.
Okay, I'll entertain a motion.
Motion to approve with the updates on the screen.
Second?
Second.
Thank you. Let's vote, please.
Brian Duty.
Oh, it's loud.
Aye.
Oh, sorry.
Really loud.
Brian, did you vote?
Yeah, yes, yes, and yes.
Okay. Mary Beth Engrove.
Yes.
Adrian Irwin.
Yes.
Max Kaiser.
Yes.
Sarah Love.
Yes.
Chris Pinzon.
Yes.
And Holly Jo Hodges.
Yes.
Motion passes.
Yay. One down for ENT. All right, next. Oh, the computer has to think a second. The next one up is oops. Septoplasty, rhinoplasty, and nasal polyps. Everybody's
Page 148.
favorite. So these are different procedures. The septum is the thing in the middle of your nose that separates the two different nostrils. It can be damaged, formed, injured, etc., and can affect airflow through the nose. It is sometimes done to correct function of the nose or when it's causing like chronic sinusitis. Rhinoplasty is a procedure to fix the nose, typically done after injury or disease, where the nose has to be reconstructed. Rhinoplasty and septoplasty are also performed pretty frequently simply to enhance cosmetic appearance. And nasal polyps are growths in part of the nose that can occur, usually due to nasal allergies. They are problematic when they obstruct airflow or they obstruct the sinuses and cause chronic sinusitis. So our last review of rhinoplasty and septoplasty was in 2021, and we developed new guidelines for septoplasty and rhinoplasty based on that review, based on private payer policy with local expert input. However, some of the procedures that are in those guidelines are on currently non-funded lines. So nasal surgeries appear on a whole bunch of different lines for upper airway, like craniofacial anomalies, injuries, cancers, sinusitis, etc. So the ENT position statement from 2021 on dilation of sinuses, etc., is that you should have. So this was put in here because of some concerns of other folks that sometimes the sinus surgeries are overutilized. So basically, you need to fail conservative therapy before you have surgical dilation, etc. So we had again 2 ENT experts. They did recommend coverage of deviated nasal septum when it's causing or contributing to sleep apnea or recurrent sinusitis. And of note, nasal surgery is currently explicitly not covered for obstructive sleep apnea. And you'll hear a whole discussion about surgeries for obstructive sleep apnea in a little bit. And if the nasal septum deformity is severe enough to cause obstruction in breathing, our experts also thought it should be surgically corrected. These indications are all in the current septoplasty guideline. And then Dr. Kelly, who's our pediatric ENT, recommended coverage of a specific code for a quick office procedure for apparently during birth. You can have some birth trauma that dislocates the nasal cartilage, and she just does this she just does it in the office on a newborn. Occasionally, sometimes it has to do it for an older child under anesthesia. Current coverage of acute nasal fractures and chronic nasal fractures and repairs were felt to be adequate. Experts thought that our nasal polyps were generally treated with medication and that surgery should only be done if it causes nasal obstruction, chronic sinusitis, or sleep apnea. And again, we explicitly don't cover nasal surgeries for sleep apnea. The major private payers all have the same coverage that we currently have in our guidelines. So the recommendation, this would be for 2027 with the BUP changes, would be create a code grouping for rhinoplasty, septoplasty, and chronic sinusitis surgery. All of the chronic sinusitis diagnoses and procedures would be added, as well as a variety of other codes that were in the extensive tables that you can see attached. And we would have multiple guidelines with only technical changes done. And then we would have some technical changes to the sinus surgery guideline. So essentially, you see the sinus surgery guideline with no changes. Septoplasty, again, would only have the technical changes. However, we have a current note in that guideline saying that nasal obstruction is a non-funded diagnosis. That would need to be struck because that would no longer be true. And the effect of that would be we would now cover treatment of nasal obstruction because of septal deviation. So that would be an expansion of coverage, just to note that for you. And then rhinoplasty would be medically necessary, essentially if it's causing issues, and same with rhinoplasty, they have to be causing airway obstruction, or you need to have this done as part of your sinus surgery for your chronic sinusitis. And then there's the whole bunch of the fun code tables. Any questions, discussions?
Yeah,
Hi, this is Mary. So, go ahead. I apologize.
No, go for it.
Oh, thank you. So basically we're saying we'll cover nasal obstruction, we won't cover sleep apnea. And then can you show me what, as far as like for trauma, for rhinoplasty, what we're saying for the criteria for that?
We currently have a guideline. I didn't show it to,
I think it defines acute fracture as less than 14 days old.
It's on the very bottom. I think it's that guideline, no?
Okay.
With that one.
Yeah.
Keep going down. It's at the bottom of one of them.
Okay, so it's not rhinoplasty then. Let's look at septoplasty.
I don't know. I think that may be a separate guideline. Let me see if I can pull up.
14.
Is there a separate septoplasty?
It's at the bottom of
Or search nasal reconstruction?
Because we do have a guideline that we define, like you can get you can get it for acute trauma, you can get nasal surgery, but not for
part of
sequelae.
rhinoplasty, 216. It's, do we have that?
Oh yeah, a care for acute nasal fractures up to 14 days for injuries included on line 227. Sequelae of nasal fractures, nasal deformities is included on line 570. Did that not get carried over to 216 on this?
There we go.
Yeah, I think I got cut off. It's the very bottom.
Yeah, the last sentence of 216 got cut off. So I'm going to email that to you really quick, Liz.
What's the medical reasoning for covering nasal obstruction? Because it's annoying, but you can breathe out of your mouth. It seems, I'm not sure how it's medically necessary, and by our usual thought process, I would think of it almost as convenience. If it's not causing recurrent infections, etc., just obstruction.
I think the ENTs would say that it can affect your ability to do things. I don't know how evidence-based that is.
Yeah, I've seen a lot of those statements, and it doesn't follow for me because your airway combines, right? Just below your nose and your mouth eventually go to the same tube. So if you can breathe out of your mouth, again, it's annoying. Like I wouldn't choose it, but I'm not sure how medically necessary it is.
Isn't it still restrictive? I mean, I know even when I have a cold or something, it's miserable, but it feels restrictive because
Right,
you're
it's not
also
fun.
limiting,
Well, you have
you
a tube
can't
there and
eat
a tube
and
there.
breathe at the same time.
That's fair. That's true. You're not really breathing when you eat.
I don't know. My husband has one completely included, which he didn't know, so we started doing yoga.
Yeah, I guess my question is, what is the data for that? What is the purpose? It's to me not incredibly clear, and before we would expand coverage, I'd like to have more knowledge and support of that.
Well, I think your concerns are valid because, like, when you're reviewing these charts, right, there's always so much overlap and subjectivity with the request. Some are very, very clear cut, right? Like there's complete opacification of the sinuses, and then you get onto the other end of the spectrum. It's like prior rhinoplasty, and this is very common, prior rhinoplasty non-nasal valve collapse. And so that's a very different situation. But I think there is an incredibly large gray area, so completely understand your concerns with that, Max. It does just get really complicated.
Yes, Paul. Yep.
We could wordsmith things so that we don't cover, what we don't cover currently because it's below the funding line. So that would be nasal obstruction with documented we could strike out. So you could have septoplasty when there's recurrent epistasis or recurrent sinusitis, but we could cross out C if you're concerned about that.
Yeah, that would be my.
That may be reasonable.
You want to cross out this entire C.
Mm-hmm. Is nasal valve collapse? I thought that was moving to cover.
That's excluded.
Okay.
It's the very last code in the very last table, repair of nasal valve collapse.
Okay.
Excluded.
And for the rhinoplasty?
Wait a minute. No, there's nasal valve, there's two codes for it. One is currently on the rhinoplasty lines, the 30468. We could exclude that too.
Same thought. Yeah, I would.
This one?
Yeah, that one right. Yeah, 30468.
And also, okay, so that one.
30468. Exclude that one's fine. That one is a different procedure. It would be the one above it. It would be just excluded as cosmetic or something. Or do you want that to be not medically necessary, which would allow you to prove it by exception, I suppose?
I mean, can't I prove anything by exception?
I think it would be.
Excluded. Let's make it not medically necessary.
Correct. Yeah, it's not excluded from the benefit package. It's not medically necessary because
And were we adding that they have to have disease on CT and endoscopy and also be treated for allergic rhinitis if it's present? Were we adding those? Those are recommended by updated guidelines, right? If I understood correctly.
So we currently have chronic sinusitis. You have to have findings of obstruction on CT or mucocele or negative CT but disease found on nasal endoscopy.
Right, and the new ENT, didn't you say the new ENT guidelines required it on CT and endoscopy?
That's unclear, actually, if you read the actual guideline.
Oh, I thought you said it did, okay.
It's unclear from the way they worded it, what they're actually recommending, and since I was unclear, I was going to the experts had kind of.
So, hang on a second, Marcus, what did you say?
Well, I was the one that referred it to Ariel, and my read of the guidelines was that they required maxillofacial CT, not for diagnosis, but to move from diagnosis to treatment with balloon sinuplasty. But if Ariel read it differently, then I would defer to her. That's.
I thought even the experts said that we should do that because the guidelines said that, but I might have misread it. I'm reading it secondhand, not first. But
I think the experts would go with the more liberal version.
yeah, that would have been I was surprised, which is why.
The concern is that the sinuplasty is performed on all available sinuses without definitive evidence of disease in a specific sinus. So if someone has chronic sinusitis diagnosed, you would want to target which sinuses you're going to intervene on based on the CT. That's why you would need the CT to identify, is it the frontal, maxillofacial, which side, instead of just ballooning everything.
They do seem to recommend additional procedures when they are doing surgery, whether there's disease noted there or not. And use language kind of, we're in there, we should do this anyways. That's why I was thinking of including it, but I guess if it's questionable, then we can leave it. And I'll defer to both of you because I didn't read it. They did recommend adding in treatment for allergic rhinitis though if it was present, correct?
Yeah.
Because I'd add that too. I mean, I consider that kind of conservative care, but
Allergic? Sinusitis?
not fungal. So for recurrent sinusitis, it's essentially conservative treatment both for
For D above, it says, well, we say medical therapy defined as 2 or more courses of antibiotics and a trial of inhaled or oral steroids.
which sort of gets to the allergic rhinitis, but I don't think I would say somebody failed if they just had nasal steroids. I know they're technically more effective than oral antihistamines, but there's a couple other things you can add on there that are much less invasive. There's 2 oral medications, 2 nasal sprays that could potentially help that are less invasive than surgery.
Saline rinses as well.
Yeah, nice. Yep.
So for B, antibiotics, and then do you want to just say and adequate treatment of nasal
I just
allergy?
say, yeah, you can just say adequate treatment of allergic rhinitis. I think it's too complicated to get into all of the medications and such, because there's some debate about one oral in certain populations.
So and adequate treatment of allergic rhinitis if present, I guess.
Yeah.
And then take out the trial of adequate doses of inhaled or oral steroids?
No, I think that's helpful too, because
Don't take it out.
yeah,
So you
that's reasonable if
and
you don't have allergic rhinitis. That's
adequate, what?
So add another and. So
Commas.
appropriate medical therapy defined as 2 or more courses of antibiotics and adequate treatment of allergic rhinitis if present and a trial of steroids.
That's,
Thank you, Liz, you're amazing.
On hands.
yeah, that's
It's a grammatically incorrect sentence.
Can you do?
I think take out the first and, just leave the comma.
Yeah.
Adequate.
No, I
So we
think
need both ands.
we do because
it's 3
you have to
different
have, it's either and or, so we need to know which one, so. Just for clarity of visual for the moment, could you just drop, enter after the second and, so we've kind of got like a.
They'll make them into a list.
Okay.
Less, yeah,
Or an
exactly.
outline.
It's,
More like a bullet point list instead of a run-on sentence.
yeah, it's just, it's a parenthetical.
Yeah.
So that's
So that one.
a list.
So appropriate medical therapy defined as colon.
Find as, okay, thank you.
Do we want to say you guys can wordsmith it later and move on because we don't have a ton of time?
We're almost.
Okay. More thing.
And then we'll have to indent 1, 2, and 3 below.
Yeah, in addition to.
So you have to indent 1 and 2 and 3 below. Beyond A, B, and C.
Because
Yeah, but
those
that
all
doesn't,
become,
that doesn't
yeah,
set up
subset of
with the right
C.
parentheses, that's not correct with the parentheses.
Sorry, it's like, it's Microsoft Word is. sometimes you have to-
Oh, and then and one or more of the following in your C now, this needs to be hanging by itself after the C before the 1.
It's not what I need.
Okay, yeah.
Okay,
We'll
Fix the formatting
yeah,
later.
but the wording is correct. We good with that?
Yeah.
The wording makes sense, everybody online, okay.
Yeah, okay.
All right. Where are we at?
you could move to approve the modified staff recommendation. And we have changed this chronic sinusitis guideline, as you see. We've struck the nasal obstruction from the septoplasty, and then we've added an additional sentence that got left off of the rhinoplasty guideline about fractures with the appropriate modifications. And then we are making nasal valve collapse repair not medically necessary.
And just to be clear, we didn't add, you just brought it back because it was left off. The line about nasal fractures.
Correct. It was inadvertently left off, and I apologize for that.
There we go. That's what we need for the record. Thank you. All right, other thoughts, questions, or I would be happy to entertain a motion.
Motion to approve what Ariel just said.
It's Mary, I second.
Mary seconds, and let's roll call, please.
Brian Duty.
He said aye. He meant yes.
Okay, yes.
And Mary Beth Angrav.
Yes.
Adrian Irwin.
Yes.
Max Kaiser.
Yes.
Sarah Love.
Yes.
Chris Pinzon.
Yes.
And Holly Joe Hodges.
Yes.
Unanimous.
Hey. All right, moving on to salivary gland issues.
Page 160.
Thank you. So there are several problems that can happen with your salivary glands that make the spit in your mouth. You can have cancer in there, infections, you can have stones, and you can have too much or too little saliva. Stones can completely block the duct. They can cause pain. They can cause infection. Usually those are conservatively treated with massage or medications that increase salivation. Antibiotics can treat infection. And according to our experts, stones that are less than 5 millimeters should undergo endoscopy, and impacted stones, or those larger than 5 millimeters, you actually need to do a little surgical procedure to get those out because they can become chronically infected. You can get chronic inflammation of the salivary glands, usually with an autoimmune disorder like Sjogren's syndrome. You can get fever, pain, swelling, and pus discharge from the gland. Treatment for that is injections, medications that increase saliva, and surgery. Mucoceles usually don't need any treatment, although the ENT experts did recommend excision when it's close to the lip or causing issues with lip function. And then when there's uncontrolled salivation, which can happen mainly in virologic diseases, it can cause skin breakdowns and other complications, and they usually treat that with botulinum toxin. So currently, we cover on various lines the sialoadenitis, which is the inflammation or infection of the salivary gland, abscesses of the gland, and fistulas, and they have appropriate treatments. We currently don't cover the chronic drooling or kind of chronic salivation. The experts recommended covering this when it causes skin breakdown. They see this a lot in patients with Parkinson's disease. When patients can't effectively swallow their saliva, they can have a lot of skin breakdown, and the chemodenervation can be really helpful. They recommended adding coverage for removal of stones without complications if it can't pass with conservative measures. They didn't feel we needed to treat atrophy or hypertrophy of the salivary glands. And then they felt that mucoceles basically should be covered only near the lip, which actually has a separate diagnosis that's currently funded. So they thought we were fine with our current mucocele coverage. Private payers do cover the stones. So the recommendations would be a whole bunch of additional things. So atrophy and hypertrophy of the salivary gland would be evaluation of medical management, but then the sialoadenitis, which we currently cover, would stay covered kind of in the new code group. And then we would add a few other things that currently aren't covered, like the stones, the sialolithiasis, to that code grouping. Well, there's some cancer codes and things like that that are currently covered. So the main coverage change would be adding to coverage the sialolithiasis. And there's a whole bunch of treatments for that. And then we would change our current Botox guideline to allow treatment for excessive salivation when it results in skin breakdown, skin infection, inability to handle oral secretions, which increase the risk of aspiration pneumonia, and you haven't responded or have contraindications to pharmacotherapy. And that's based on our expert input.
How often do the stones get infected?
I was not able to pin down our experts on that particular issue.
I mean, that's relevant to me because we don't do a lot of preventative things like that. Like if you have gallstones, we don't take out your gallbladder unless they're causing a problem. And right now, we already cover when they're causing a problem, right? That's what I heard.
Yeah, so we could make the sialolithiasis just evaluation of medical management, which would be kind of continuation of what we currently cover. That's the K11.5.
I mean, if they can't point to a high percentage, I don't see why we would begin covering it.
Okay.
Should I make that change?
Makes sense.
Okay.
Sorry, all online. We're just all.
That's all right. You need to eat. Keep your strength up.
So what about like K11.21 then, the acute? Oh, no, sorry, that's a sialolobinitis instead of.
Oh, and the mucocele, that should actually be evaluation of medical management, the K11.6. They didn't think that it was actually a problem. I don't know how it got to 320. And then pretty much everything else is evaluation of medical management that we don't currently already cover. Yeah, everything else is current coverage essentially. Any questions about the guideline changes that would add some coverage for excessive salivation? I think that's pretty reasonable. I think they would do that in cases mainly with neurologic issues.
Motion to approve with those modifications.
Second.
Thank you. We'll roll call.
All right. Brian Duty,
Yes.
Mary Beth Ungrave,
Yes.
Adrian Irwin,
Yes.
Max Kaiser,
Yes.
Sarah Love,
Yes.
Chris Pinzon,
Yes.
and Holly Jo Hodges.
Yes, sorry.
Okay. Unanimous. Motion passes.
She was salivating.
Sorry, I just took a huge bite of my sandwich. All right, we're making progress. Good job, Ariel. Vocal cord.
All right, so there are
Page 166.
There are multiple issues that can happen in the larynx, which is the voice box, or with the vocal cords. They can affect breathing, speaking, and swallowing. They can be congenital or they can be acquired later in life. They can do bronchoscopic or open stenting or surgery or other corrections. Vocal cord paralysis is a voice disorder when one or both of the vocal cords don't open or close properly. Single vocal cord paralysis is common. Paralysis of both vocal cords is rare and can be life-threatening. Vocal cord paralysis is usually caused by injuries to the nerves that feed the vocal cords from surgery or tumors or infection. And people with neurologic disease like MS or Parkinson's, strokes, etc. It can result in a hoarse or breathy voice, a shortness of breath, swallowing problems, choking, and coughing, because the vocal cords can protect your airway when swallowing. And Treatments are typically voice therapy. They can be, you can do surgery. When both vocal cords are paralyzed, a tracheostomy may be required to help to ensure that you can continue to breathe. There is laryngeal spasms, which is like a muscle spasm, but in the vocal cords, it can make it difficult to speak or breathe for a short time. Usually treatment is of the underlying cause. It's typically GERD. It can be other neurologic issues. There's spasmodic dysphonia or laryngeal dysphonia is a chronic neurologic disorder that causes spasms in the voice box muscles, again, making it difficult to speak. Usually it's treated with Botox or voice therapy. Benign vocal cords, benign polyps of the vocal cord is below the funding line currently, although it once was above the funding line and moved below for unclear reasons. And by 2017, it was there. No discussion was found as to why. So chemodenervation of the vocal cords was discussed in 2004 and 2016, and no evidence was found for coverage and in either of those discussions. We are dealing right now with 2 covered lines and 2 uncovered lines. So the laryngeal stenosis or paralysis and the dystonia and laryngeal spasms are currently covered. Paralysis of vocal cords and spastic dysphonia are currently non-covered. Our ENT experts recommended covering chemodenervation for spastic dysphonia when it caused functional problems. They were also worried about recurrent papilloma from HPV infection because it can become an airway concern. However, when staff kind of researched that more in more detail, it's actually a different code, laryngeal papillomatosis, which is on a covered line and has all the correct CPT codes for treatment. A single benign polyp just needs a diagnostic biopsy and perhaps voice therapy. It's usually an overuse of the voice as a cause. So the staff recommendations are to create a new code group, laryngeal stenosis or paralysis and laryngeal spasm, based on current line 66, and include all of the current things that are on line 66, but also include a couple of injection codes that are currently not on that line that should be. These are not Botox injections. They're for other medications that may be used. And then rename code group 359 to dystonia because we're moving the laryngeal spasm up to the laryngeal stenosis line where it sort of more appropriately exists. And that line has the chemodenervation on it. And then there'll be some code movements. So most things will stay on there. If they're on a covered line, they will stay there. Paralysis of vocal cords unspecified will be moved up to match the other vocal cord paralysis. It was just the unspecified and the that were there. The unilateral and bilateral are on 66 already. And then polyps are just evaluation of medical management. Same with nodules. Other diseases of the vocal cord should be on line 204. That is used for vocal cord abscesses. And then a laryngeal spasm, we're getting rid of that part of line 59. It'll be moved to line 66. Just a kind of a lot of movement around, but not a lot of new coverage. And then we will modify our current laryngeal stenosis, basically just technical changes. There was one consent, we added a code in March, so that's why there's one little bit in there in purple. And then we'll strike out other diseases of the vocal cord that says that code's only there for abscesses because we'll put it on the abscess line. And then we will continue to say that chemodenervation of the larynx and vocal cords is not effective and should be excluded services guideline 2. Questions for me?
So the only coverage expansion that I saw was that up here.
We'll be covering unspecified paralysis of vocal cords. That's the only code that's currently non-covered that will become covered. except for a couple things that will be available for evaluation and medical management.
Yeah, okay. Yeah. Got it. That's good. Other questions, discussion, entertain a motion?
Why did we move the unspecified code? Did I miss that?
Because unilateral and bilateral are covered, unspecified. I think we've never liked unspecified codes, but I've given up. ICD-10 is so awful, people just code whatever.
Yeah, I really don't like unspecified codes too, because it just lets people basically do whatever they want if it's covered.
So we're covering unilateral and bilateral, so I don't know what would be unspecified, like 1.5?
Yeah, no, I don't know either.
I mean,
That's kind of part of the
I
problem.
think that's what the question is.
Yeah, I'm not enough of an expert, so I just usually leave those off, because if there isn't, and if there's a good enough exception, then we keep that, but
You could make
just
that
worry about
evaluation
those.
and medical management instead of putting it in the code group 66, if that feels better to you.
Yeah, that's what I prefer. Again, I'm a person.
Hi, it's Mary. I have a question on the unspecified codes. Were you talking unspecified diagnosis codes or CPT codes? I would miss that.
This
Apologies.
is the ICD-10 code. It is J3800.
Oh, gotcha. Okay. Oh, got it. Got it. Thank you so much.
And then everything else.
Entertain a motion of any
It's
kind?
Mary. I moved to approve. Move to approve.
Thank you. We're gonna take that to mean as written with those friendly amendments. Okay, great, and seconded by Brian. We'll go ahead and vote, please. Jessica, thank you.
Okay, roll call. Brian Duty,
Aye, or yes.
Mary Beth Engrad,
Yes.
Adrian Irwin,
Yes.
Max Kaiser,
Yes.
Sarah Love,
Yes.
Chris Pinzon,
I'm sorry, I had to step out of the room, so I'm gonna abstain. I didn't hear the discussion.
and Holly Jo Hodges.
Yes.
Motion passes.
All right, we have about 5 minutes before we need to start the coverage guidance. Ariel, do you want to try to do one more, or should we
Take a
come back?
5-minute break. Is that okay with y'all? And we have 3 ENT topics that we'll table till August.
Unless we get there at the end of the meeting,
I
yeah.
was like, gonna do it, okay. All right. So you said you want a 5-minute break? Yes, because you all are not getting to eat, so yes, we should do that. Sorry. So let's how about a 10-minute break so you can like get water and go to the bathroom, so.
How we can just do 5 minutes, because I can eat a little snack while the Center for Evidence Policy folks are talking.
Well, you're not the only one online, so how about can we wait until 12:05, are we good? Okay, 12:05. 10 minutes. I always feel so bad about everything making
the camera.
Are we on?
We are on.
We are on. Okay, we are ready to go.
All right, thank you.
Marcus,
Thank
take
you.
it away.
Yeah. So my name is Marcus Bachhuber, and I'm with the Center for Evidence-Based Policy, and I'll be presenting to you today on our research on surgical treatments for obstructive sleep apnea. So we presented this to EBGS previously, and so we'll be presenting it to you and then to HERC later today. So we have no conflicts to disclose, and the full draft of the coverage guidance can be found in the meeting materials for today. Some of you may already know this, but the Center for Evidence-Based Policy, we're based at OHSU, and we're contracted by OHA to carry out these systematic evidence reviews. We perform reviews using widely accepted and rigorous methods. We basically carry out the scope provided us by the HERC, and if we have questions or clarifications, we work with HERC staff. We only provide the evidence. We don't recommend any coverage decisions or have any role in that process. Just a reintroduction to our team. So you can see me, our research director, Dr. Val King, Shauna Durbin, who's our lead researcher for working with the HERC, and then Courtney, Jen, and Jana, who are research associates who work on this project. We were very lucky to work with two appointed experts, Derek Lamb and Louis Libby, who I think may be on the call today, who were very helpful in all aspects of this project. So this is the second and final.
Jessica, could you actually promote Dr. Libby? Oh, looks like you did.
Great, thank you. So this is the second and final part of the evidence reviews on obstructive sleep apnea surgery. The first on hypoglossal nerve stimulation was discussed previously and was tabled for 1 year to revisit, so you'll probably hear that upcoming. Okay, so this is a pretty abbreviation-heavy field, but I tried to break it down for these slides, and so I'll explain these abbreviations at first use. So obstructive sleep apnea, or OSA, is a disorder where breathing is interrupted during sleep, which results in disrupted sleep or low oxygen level in the blood, or both. You can see the diagram on the left is a normal airway where air is moving through the nose and mouth into the lungs, and then on the right, the soft tissue of the neck and mouth have blocked the airway, and so the air can't basically move into the lungs during sleep. And it's a relatively common, estimated to affect 9 to 38% of the population. OSA causes lack of restful sleep, daytime sleepiness, headaches, and other symptoms. It's associated with reduced quality of life and cardiovascular diseases. It's diagnosed through testing in a sleep lab or at home to identify obstructive respiratory events. And these are two categories: apneas, which is a complete cessation of airflow, and hypopneas, which is a reduction in airflow, accompanied by a reduction in oxygen saturation. So Medicare and OHP and other payers use the AHI-4 definition, which is a reduction in oxygen saturation by 4% or more. The count of these events, apneas and hypopneas, is referred to as the AHI, or apnea-hypopnea index, and it can help you classify OSA into mild, moderate, or severe based on those cutoffs you see there. The oxygen desaturation index is also used, and that's the count of desaturation. So for OSA, we can also measure patient-reported outcomes using several validated questionnaires. These include the Epworth Sleepiness Scale, Functional Outcomes of Sleep Questionnaire, and General Quality of Life Scales, which are sometimes used in research settings, less in clinical settings. For treatment of OSA, the first line is positive airway pressure, or CPAP, and you can see there it's an external device that creates a constant flow of air to support the tissue of the airway to remain open. And when we get into surgery for OSA, the purpose of surgery is to address any abnormalities in the structure or function of the upper airway. So you can see that cross-section of the head and neck there. The surgery can address abnormalities or issues in the hard palate, which is the bony part of the roof of the mouth, the soft palate, which is the soft tissue of the roof of the mouth, tongue muscles, or any of the tonsils. Surgery can also potentially improve the efficacy and tolerability of CPAP therapy, and surgical techniques, like all fields, are constantly evolving. And because OSA occurs during sleep, we know that breathing patterns and breathing anatomy can be different when you're awake versus sleeping. And so drug-induced sleep endoscopy is a diagnostic test to examine the airway anatomy under light sedation to mimic sleep. And it can help identify specific structures that are causing obstruction during sleep. surgeon can use DICE to guide their approach for any surgical intervention. So patients that are candidates for OSA surgery really depends on the recommendation for surgery, and specific procedures are tailored to the patient's anatomy and based on the surgeon's clinical judgment. Also, surgeons themselves are proficient with specific procedures, and patients can be selected by surgeons based on the clinical appropriateness of those procedures. So like most things in medicine, but even to a higher degree, there's no one-size-fits-all approach for OSA surgery. And patient variation in anatomy, as well as surgeon variation in preferred procedures, can also complicate research and the application of research results to clinical care. So taking a step back and looking at surgical treatment or surgical research more broadly, surgical research generally includes fewer RCTs than other fields. And even in surgical RCTs, there are challenges in using standard methods like blinding, also known as masking. So these challenges are kind of inherent in the surgery, and so when we identify them, it's not a critique of the researchers or a comment on what they should have done. This is just kind of inherent in the intervention itself. But at the same time, those limitations can impair our ability to determine cause and effect. So we, examine these studies just like we would with any other intervention. Now moving on to the scope statement and methods. So again, this is the scope statement that was assigned to us by HERC that you all participated in developing. So we looked at adults with moderate to severe OSA, and by definition excluded those populations you see there. We looked at all surgical airway interventions, including upper pharyngeal procedures, lower pharyngeal and laryngeal procedures, and maxillomandibular advancement or expansion surgery, which is a jaw procedure, and we'll talk a little bit more about procedures as we get on with it. We excluded prescription drugs, hypoglossal nerve stimulation devices, because those are in separate coverage guidance, nasal surgeries alone, and any airway surgeries not used in contemporary practice, as well as tracheotomy or tracheostomy, which are typically an intervention of last resort. For comparators, we included non-surgical OSA interventions, such as PAP or oral appliances, waitlist or no treatment, and we excluded studies that compared surgeries to surgeries. Those are included in a separate comparative effectiveness question. For outcomes, HERC selected 2 critical outcomes for quality of life and procedure-related serious adverse events, and 3 important outcomes: change in OSA severity, daytime sleepiness, and major adverse cardiac events. For study designs, we included, for the effectiveness questions, randomized controlled trials of any size and comparative prospective cohort studies of greater than 100 participants. For harms, we included those studies as well as systematic reviews, single-arm prospective non-randomized studies of over 100 participants, and registry studies. So you may be asking yourself, why were the different designs for different questions? So for effectiveness questions, the best design gets at cause and effect as directly as possible. So those reduce or remove key biases, such as selection bias. So the prime example here is the randomized double-blind placebo-controlled trial. And generally, we want to limit or exclude study designs that are biased because they may just add noise to the picture. For harms, it's kind of, you flip it on its head. We want to get as much data as possible. So randomized controlled trials are often inadequate to determine safety because they are too small or too short of a duration. Better designs have a large and representative sample with a long follow-up period. And so these studies can find a broader scope and magnitude of serious adverse events, including rare ones. And some examples here are national registry studies and large cohort studies. But in general, we want to include all available data. Another thing that comes up is the importance of a comparison group and looking at effectiveness. So a comparison group is important because if you don't have one, you can overestimate the benefits of your intervention. So in this diagram, we have a hypothetical intervention where the blue arrow is the intervention. You can see OSA severity decreased from baseline to follow-up in a pretty large amount. So if you look at that decrease, you may say, wow, that was an extremely effective intervention. But when you include a control population that maybe got some patient education or just participating in the trial led them to take their OSA more seriously, or they learned some tips around sleep positioning, things like that, you can see those folks also improved. So if you then compare the difference between the control and intervention, it's much smaller than if you looked at just the intervention alone. And that difference may still be important and it may still be significant, but it's that difference between intervention and control more reflects the specific contribution of the intervention over and above what would have happened otherwise. Another question is, why are large studies important for harm? So the rarer the adverse event, the larger the sample size is needed to detect it. And so this graph on the vertical axis is a measure of statistical power. And I've marked there with a dashed line 0.08, which is generally the threshold for adequate statistical power. And on the horizontal axis is the sample size and observation time. So there's three types of adverse events, and these are just illustration purposes only. An uncommon event, that's the gray line. A rare event, that's the red line, and a green line, which is a very rare adverse event. So you can see, as the rarity increases, the number of people you need to look at and the number of time you need to follow them to have a reasonable chance of detecting that adverse event increases pretty dramatically, from around 5,000 for the uncommon to probably over almost 10,000 or 8,000 for the very rare adverse event. So the key contextual questions assigned by HERC were, the first is what is the effectiveness of surgery versus non-surgical treatments for OSA in adults? Second is around the harms of surgery. The third is the effectiveness and harms of the interventions by intervention and patient characteristics. There were three contextual questions. The first was looking at evidence of effectiveness for surgery on outcomes from other types of study designs, and we'll dig a little bit more into that in a bit. And the second was, what is the comparative effectiveness of surgery for OSA? And then the third is, what is the cost effectiveness of surgery for OSA? First, our search and selection methods. We worked with an information specialist to develop a search strategy using multiple evidence databases. And then for policy items, we searched at the sources you see there. We did dual review of search results and risk of bias, and we did methodological quality assessments by dual independent review. For our evidence synthesis, bringing it all together, we use the grade system, which ranges from very low, that 1 dot, to high, which is that 4 dots. So very low being the true effect is likely to be substantially different from the estimate of the effect, and high is that we're very confident that the true effect lies close to that of the estimate of effect. And then, as I mentioned, we were very fortunate to work with two incredibly skilled or experienced clinical experts, and we reviewed. They participated in scoping. We reviewed the list of included studies and clinical guidelines with them, and we reviewed our findings and evidence synthesis with them. And we had the opportunity to really get feedback and hear any things that we missed or interpretation. They really helped us understand this pretty medically complex issue. So thank you again to them. And they're also invited to participate in the public meetings, and they were there for EBGS as well. So let's jump into the results here. So we identified 2,390 publications, and which we screened for eligibility, and resulted in 13 studies of 16 publications that were included for the key questions. And then there were 8 what we called evidence-based recommendations. So these were policy statements, position statements, guidelines, things like that got filtered into that section of the report. We found eligible studies on these 3 types of procedures. The first is uvulopalatal pharyngoplasty, or UPPP. That was the most common type of study, or most common type of surgery that was studied. The purpose of this surgery is to remove or reposition excess tissue from the throat to widen the airway. So you can see on the left, you have a more crowded airway, and then after the UPPP, the airway is wider. UPPP is interesting because it was developed a while ago and has kind of evolved. Surgical techniques have evolved. So it's not a singular procedure, it's more kind of a family of related procedures. But where the procedures were distinct enough to be considered different surgeries, we consider them different surgeries, but just to note that. There's also barbed repositioning pharyngoplasty, which is a similar concept to UPPP. It's in the family of UPPP, but it uses special sutures to reposition the pharyngeal palate muscle to widen the airway, you can see there. The third surgery that we found was maxillomandibular advancement, or MMA, and that surgery repositions the bones of the upper and lower jaw to widen the airway. And because of repositioning the jaw, it typically requires subsequent corrective dental treatment. So we found for UPPP with tonsillectomy, there were 3 RCTs, 2 systematic reviews, and 2 registry studies for about 13,000 participants. For MMA, there was 1 RCT and 1 systematic review with about 631 participants. For broad repositioning, pharyngoplasty, and tonsillectomy, there was 2 studies with about 1,500 participants. And the last study was, they described it as multi-level, multi-stage surgery. And so all of those folks in the beginning got a UPPP with or without tonsillectomy, and they may have gotten subsequent surgeries. So this study we grouped with the UPPP and tonsillectomy studies. So for our first critical outcome is quality of life. So we found 3 RCTs and 1 cohort, and the data were limited by risk of bias. So there's a lack of blinding in these studies, again, for the reasons that I mentioned previously, but lack of blinding with the patient-reported outcome predisposes to biased outcome reporting. And there was limited methods reporting and a lack of funding information. So we downgraded it for risk of bias for 2 levels. So all in all, we rated the low confidence of benefit for quality of life, grouped the studies into 2 categories: surgery versus waitlist or no treatment, and surgery versus PAP or medical management. In the interest of time, I'm not going to go through the individual studies here, but we have a summary at the end where we talk about whether the studies met minimal clinically important difference or MCID. So for the FOSQ scale, that's the functional outcomes of sleep questionnaire, 2 of the 2 studies met the MCID. For the SF36, which is a quality of life questionnaire, 1 of the studies met the MCID for the mental health but not the physical health component. And for the EQ5D, there was no MCID. And for the Glasgow Benefit Inventory, which is a questionnaire about the surgery or the benefits of surgery, there was no MCID identified. But that 1 study did not meet statistical significance. For procedure-related SAEs, we use the definition that is used by the FDA as outlined in the CFR. So that includes death, life-threatening adverse events, inpatient hospitalization or prolongation of existing hospitalization, persistent or significant incapacity or disruption of the ability to conduct normal life functions, and congenital anomaly or birth defect. So in general, if a study investigator labeled an adverse event as serious, we went with that. If they didn't say it was serious or non-serious, we would compare the description of the SAE of the adverse event to this list to determine whether we thought it was serious or not. For the studies, we found studies comprising about 15,500 participants, and we downgraded confidence for indirectness. So this was mainly an inability to determine the level of seriousness and differences in categorization of the adverse events between the studies. So we found moderate confidence in harms, and so this rating is different because the studies actually reported harms, but we assess the level of confidence that we understand the full scope and magnitude of the harms as described in the literature. So by procedure, UPPP with tonsillectomy, total serious adverse events were reported in 0 to 7.1% of participants with repeat surgery in 2.6%. And death in 0 to 0.2% of participants, but that couldn't necessarily be attributed directly to the procedure because of the research design. There were some adverse events you see there that we couldn't necessarily determine the seriousness, so they could be a range of seriousness of infections or bleeding, and the way they were reported didn't allow us to determine how serious it was. For barb repositioning pharyngoplasty, there was 0% of participants had total SAEs, but specific types weren't really reported. For MMA, we found total SAEs in 0 to 18% of participants, repeat surgery in 1.7% of participants, and death in 0. And no other types of SAEs were reported. For OSA severity, we found 5 RCTs. We downgraded for risk of bias and indirectness. So risk of bias, again, the lack of blinding can predispose to biased outcome assessment. And indirectness, some studies use a different definition of AHI than OHP does, which may overestimate the effect of surgery. And the alternate definition of AHI may have led to enrollment of patients with less severe OSA. So they might have responded differently to the intervention than an OHP patient who would be eligible for the intervention. So for this outcome, we found low confidence, or we assessed as low confidence of a benefit, those 5 RCTs with 315 individuals. again, in the interest of time, I'm gonna skip over the individual study results here. We can go to the summary. So 4 of the 5 studies met the minimal clinically important difference for AHI. 3 of 3 met it for ODI, which is another measure of OSA severity, and 1 of 2 met it for RDI. One of the study investigators proposed, instead of a minimally clinically important difference, they proposed what they call a sufficiently important difference. And so this was a difference that would account for the risks of surgery, and that they proposed a threshold of a change in 20 events per hour for AHI. And when looking at that, 2 of the 5 studies that we found met that threshold. Moving on to daytime sleepiness, we found 5 RCTs in 1 comparative cohort, and this was similar to quality of life. We downgraded risk of eyes for 2 levels for the same reason. So overall, we found low confidence of benefit, and skipping to the summary, 4 of the 6 studies met the MCID for the sleepiness scale used, and 4 of the 6 met the sufficiently important difference proposed by those investigators of greater than or equal to 3 points. For major adverse cardiac events, their last outcome, there were no eligible studies that reported that outcome.
Are you serious?
Yeah.
Sorry. The only thing that really matters.
Yeah, so for the first contextual question, the purpose of this was to provide a broader search and using types of studies that may potentially be less reliable to provide just more kind of contextual information here. So we identified 3 systematic reviews looking at the association between OSA and cardiovascular events. One was and mortality. One was on the one on mortality found inconsistent results, with the most recent study in 2004 finding UPPP compared with CPAP to be associated with lower mortality. For stroke and transient ischemic attack, UPPP versus no intervention was associated with a lower risk, and for cardiac arrhythmia, there was no significant difference with UPPP. For our comparative effectiveness question, we identified 5 studies. I just want to draw your attention to the last one, which looked at tonsillectomy alone versus a modified UPPP. So in this study, the outcomes were very similar, suggesting that in certain selected patients, tonsillectomy by itself has similar outcomes as a UPPP, and that'll factor into Ariel's recommendation when I kick it over to her. For cost effectiveness, we took into account Senate Bill 1508, which prohibits HERC from considering QALYs or other similar quality of life and general measures when evaluating health services. And we didn't find any US-based cost effectiveness studies using other measures. For ongoing studies, there were no eligible ongoing studies at the time of our search. Now we'll get into guidelines and recommendations. So this table is going to be the next few slides, so I'll just take a minute to lay it out for you. So this is from the AAO-HNS position statement. They considered a wide range of surgeries, and I only selected the surgeries that they recommended as options for patients, as potentially options for patients. I only put those surgeries on the slide. So this is just a subset of all the things that they contemplate in their position statement. Divided into the upper pharyngeal, the lower pharyngeal, laryngeal, and jaw surgeries. So I'm not going to, in the interest of time, I'm not going to just go through the descriptions of each surgery, but if you have questions, you can let me know. But UPPP is all the way on the left, and MMA is all the way on the right. Oops. So we identified 6 guidelines. You can see the methodological quality assessments there in parentheses. For the they could be divided into ones that considered only soft tissue surgeries or ones that considered MMA only. So the VA Department of Defense guideline, which was good methodological quality, only looked at MMA and recommended it. The American Academy of Sleep Medicine really did not focus on surgery, but mentioned it, so that's why we included it here. That was a good quality guideline and just recommended referral to a sleep surgeon if those criteria are met, but didn't really get into it much further. NICE also recommended referral to a surgeon, but didn't specify any other requirements, as well as tonsillectomy alone. The German Sleep Society recommended UPPP and MMA. The European Respiratory Society, the guideline was limited to MMA and ended up recommending it. and the Japanese Respiratory Society recommended against the other surgeries, but did recommend MMA. Now we'll go to payer policies. So we looked at the payer policies that we had historically looked at. So I'll start with Medicare because it seems that a lot of the payer coverage flows from what Medicare was doing. So Medicare covered U-P, tonsillectomy alone, tongue reduction, highway suspension, genioglossus advancement, and MMA. That was mirrored by Washington Medicaid, as well as the commercial insurers in Oregon, with a few exceptions around tonsillectomy alone and some additional requirements around MMA for a couple of the insurers. Okay, I will kick it over to Ariel, and Ariel, I'll advance your slides, so just let me know.
Thank you, Marcus. So based on the evidence that you just heard that Marcus summarized for you all, the changes that staff are recommending would be to add U-P for adults with moderate to severe sleep apnea and tonsillectomy alone for adults with moderate to severe sleep apnea when they're not U-P candidates. Currently, we only cover the diagnostic or the drug-induced sleep endoscopy, which is a diagnostic procedure, is only covered for children. We would need to discuss adding this for adults. Our experts did recommend it when they are evaluating whether someone is a U-P candidate. They find DICE useful. In some patients, they do find are not candidates based on that. There'll be no significant change in coverage. There's no recommendation for the MMA procedure. We would continue to cover that for children with craniofacial anomalies, just not for obstructive sleep apnea. And we continue with CPAP and oral appliances as we cover them today. Next slide, please. So this is the recommendations that were in the coverage guidance. We would recommend U-P when they have moderate to severe sleep apnea, and that would be an AHI 4. Then there's an asterisk, and that looks like a lot of just very nitpicky wording, but that's actually really important in terms of diagnosing sleep apnea. There's another one that's called AHI 3 that would have a much lower threshold of criteria for the diagnosis. So using AHI 4, they need to have a score of 15 or greater, and they need to have tried and not adequately responded to or not can't tolerate CPAP or other treatments, and they have to have the airway obstruction that Marcus had talked to you about as the cause of their obstructive sleep apnea. Next slide, please. Basically, the staff recommendation for this is based on the low confidence evidence that there's a clinically meaningful benefit from U-P compared to ongoing medical management when you have moderate to severe sleep apnea in terms of quality of life, OSA severity scores, and daytime sleepiness. These benefits outweigh the moderate confidence evidence of significant adverse effects. There are some, including death, that we would be very concerned about, but these are rare. And they would occur with any other type of upper airway surgery. And then, unfortunately, we didn't have any evidence about major cardiac adverse events, accidents, or other things that would be of extreme interest to us. They just aren't in the published literature. And then similarly, we would recommend the tonsillectomy alone when you don't qualify for a U-P. You have to have large tonsils. The Brodsky scale is the commonly used tonsillar size scale. You can be a size 3 or 4, which is very large or touching tonsils, and not be a candidate for U-P. But otherwise, you have to have the same AHI for severity and not be receiving adequate response to CPAP. Next slide, please. And this is because there is a clinically meaningful benefit for tonsillectomy alone in selected adults. And it's a less invasive procedure, and it may be appropriate for patients who are not candidates for the U-P procedure. Next slide, please. And then based on the evidence reviewed, we didn't feel that there was evidence to cover the maxillomandibular advancement surgery for obstructive sleep apnea. I want to clarify that because it is something that we might consider for craniofacial anomalies or jaw anomalies, but not for sleep apnea specifically. Next slide, please. and insufficient evidence about the advancement surgeries or other surgeries for the outcomes that we were looking at. Next slide. And so balance of benefits and harms, the benefits, which would be improved quality of life, reduced daytime sleepiness. We think that there's probably the evidence of benefits outweighs the risk of adverse events compared to ongoing medical management for patients. And similarly, to me, it's kind of same balance of benefits and harms. Next slide. Of course, this does have resource allocation. You need to have access to a specialist who is skilled in these procedures. It's a pretty extensive surgery, lots of recovery time. Also, our experts were indicating that generally they do the DICE, the diagnostic sleep endoscopy, before making a final surgical plan. So we would need to add coverage for that, which adds some cost and anesthesia risks. On the flip side, those are the costs. On the flip side, after the surgery, a patient may be able to stop using CPAP, although many patients do continue to have to use it, but they're able to get better response to it. That could be cost savings if they're able to stop using it. And then one of the other reasons, other than lack of effectiveness for not covering the MMA surgery, is that we actually don't cover the orthodontics, which would have to be done as part of that procedure. It's just currently outside of the benefit package for adults. Next. Yeah, and we also realize that many patients who either don't respond adequately to CPAP or they can't tolerate it, and they're having a lot of impacts on their quality of life, would really value something that could improve their symptoms. And they might prefer, if they were able to not use their CPAP, they might prefer a one-time treatment over a lifetime use of CPAP. However, people may be concerned about surgery, and they may be concerned about the recovery time and all of that. There are really no other options once somebody has done CPAP. There are weight loss options, etc., which are outside the scope of this, but may or may not work very well. So we're really not in a space where there's a lot of other treatment options for these folks. And you would need to have there may be some access issues if there's not suitably trained surgical subspecialists, especially in more rural portions of the state. Next slide.
That's your last slide, Ariel.
That last slide.
Yep.
All right. So do we want to go through what the recommendations would be applied to the prioritized list at this point, or do we all just want to talk about the coverage guidance?
I have a question. This is Mary.
Go ahead.
There's a great discussion on this. Wait, where did it go for the UPPP and the so my question is, okay, so, well, no, it was actually the criteria. But my question for it is, for example, when we see requests for this, or when we see requests, a more common example is when we get requests for oral appliances, like the EO485, EO486, it'll say patient failed CPAP. So the notes, it's from the requesting provider, and it'll say they failed CPAP. And then if we look, there'll either never be a claim for CPAP, or the patient will have trailed it for one day, they didn't think it fit right, and there's no attempts at trying a different mask or adjusting the CPAP. So I don't know if we should flesh that out a little bit more. I totally understand people don't want to use a CPAP. It sounds horrible, but it is standard of care. And should there be reasonable attempts at adjusting and compliance of the device documented? And then this isn't probably not the perfect time to fit this in, but for oral appliance, which we get frequent requests for, there's still no fee on the fee schedule for the EO485 and EO486, and there's a huge range of pricing submitted for that. So if someone could look at that down the road, it'd be really helpful.
Yeah, because we think we're covering the sleep device, the mandibular advancement devices, but that is an E code, which typically is not our it's DME. But I can talk to the DME folks.
They're covered, there's just no set fee schedule for them.
Yeah.
Because you say it's covered in the guideline note, so they get approved, but then there's no set coverage. And yeah, I completely agree with Mary Beth about the maybe we define a CPAP trial. I'm looking at page 203 of 220, guideline note 27. We define a CPAP trial as 12-week trial, but yet we don't define what a CPAP failure is under C of that same guideline note.
The American Academy of Sleep Medicine has recommendations when somebody isn't tolerating, so we could look at take some of those. It's like changing masks, being at intolerances. So if they get dry mouth, adding moisturizer, actually therapy, and then not, I don't think in that guideline, but other places, sometimes short-term meds can help.
Is there anything that defines like a time frame?
No, it just, if I'm remembering the wording, it's kind of, if it's not tolerated, you should try all these things. And they kind of list those various interventions, but no, I don't think they give you gotta fail 3 masks or whatnot. Yeah, I don't think.
Or any sort of time frame?
No, I don't believe so. But they do talk about things so you get that basically gradual tolerance to build up to it for certain people who are intolerant to. But no, I don't think there's a specific time frame from what I remember.
It would be super helpful if we could define a time frame and what failure means. Because I have family members who never unpacked the box. But.
Or the thought of it is anxious, so nobody even tries it. Yeah, there's a whole variance.
The box,
yeah.
just took it back.
So, I mean, I can add a little bit of information from the other, the coverage policies that we pulled that the insurers generally use this language. So failed to respond, inadequate respond, without much quantification of things. In the policies that we reviewed, I know that's probably not that helpful, but that's what we saw when we pulled up other coverage policies.
So you're leaving it up to
This
each
is
of
Chris.
us
Do we have a sleep expert that's coming to speak?
Yeah, we have two
Because I know
on the line, Dr. Libby and Dr. Lamb. Can either of you address that?
Yeah, I'm on the call. This is Lou Libby. I'm a retired sleep physician, not a surgeon, but referred many, many patients for this type of surgery. And Mary Beth brings up a very important point, both the availability of dental appliances, which are mentioned as an alternative in one of the slides. But more importantly, what defines a CPAP failure? And our fear as sleep physicians generally is a patient gets a outpatient sleep study in their home frequently and gets a diagnosis of sleep apnea based on that. And the primary care doctor says, well, we can do CPAP or we can do surgery. And the patient says, no way, I'm putting that mask on, or tries it 1 or 2 nights and says, no way, and off to the surgeon. Most surgeons, and certainly Dr. Lamb, would not consider that a CPAP failure and would send them back to someone who has more experience with CPAP, usually a sleep physician. I don't know how you put that into these criteria, but that's the fear that most sleep physicians talk about, that patients go directly from a primary care physician with limited knowledge about CPAP and how to get patients to adjust to CPAP when there's resistance. I mean, it doesn't always work, but sometimes it does. And goes directly to a surgeon who doesn't have Dr. Lamb and many others approach, which is to make sure a patient has a good trial of CPAP, usually with a sleep physician. I don't know if that helps or not, but it is a concern.
That does help. Could you put a time frame to that or suggest a time frame? What would be a time frame?
I think there's 12 weeks, and that frequently people use 12 weeks. And, you know, I don't know what the correct time frame is, but it's certainly not a day or a week. It's got to be at least a month and a follow-up appointment with a sleep knowledgeable physician. It doesn't have to be sleep boarded, obviously, you can't put that in your thing, but a sleep physician. Or a sleep respiratory therapist. There's many of these respiratory therapists who just do sleep and CPAP, and they're really good at adjusting the mask, changing the mask, adjusting the humidity, and all those things.
Thank you, that is super helpful.
This is Chris. I can tell you that what I've been hearing in some experiences, this wasn't in this state, so maybe it doesn't apply, but insurance companies will often make, in private pay, will let the patient know that the responsibility of the CPAP machine is on them if they don't have so many hours logged per night in a certain period of time.
Well,
And
that's
that's really measurable, and the machines usually capture it.
Right, that's in our criteria as well. Chris, you're really breaking up. You might want to try shutting your video off so we can hear your audio. Oh.
Is that any better?
It's pretty, yeah, it's a lot better.
Okay. Anyway, I just thought that was like good measurable data that I think a lot of private players do have out there.
Well, that's in our
And if
compliance
it's in our
data as well.
guideline already, then
It is in our guideline, Chris. It's part of the
So is it-
compliance.
yeah. So if they don't meet those criteria, wouldn't that be considered a failure?
Well, it's compliance data for ongoing CPAP usage. It's, which yes, you could say is a failure of CPAP. But what we're talking about is folks who take the CPAP machine home and may or may not try it at all, and then the next person that sees them says they failed CPAP. When we're not sure.
I see. So it's like more like intolerance. It's just not something they're going to do. Got it.
Or just never tried. CPAP's highly successful when used more than 70% of the time correctly.
I think we could put a general statement. We could say something like up to 12 weeks, including one follow-up, with interventions including mask variation, humidity, etc. Or you could even throw in therapy, all that
Talk
stuff
louder.
too. Oh, sorry, that wasn't loud enough. I think you could put in some general statements about failure is 12 weeks, including one follow-up, and then may include interventions like changing masks, humidity. You could even throw in therapy because that's in some of the guidelines. And just kind of leave it somewhat general. And we do that in other guidelines, but also calling out that we want it to be a little more than just they tried it once or looked at it and said, not for me. Probably a future wordsmithing activity.
Yeah, I'm thinking that what we'll probably need to do is staff can work with our experts to come up with some wording. I've taken some notes, but I don't know if we can get it right wordsmithing it today. But maybe we can kind of look at the coverage guidance you can all approve without doing any of that.
HERC approves the coverage guidance.
I'm sorry. So yeah, that's there. But for the staff recommendations for how we operationalize it, we can table that until staff have had some chance to work with our experts to wordsmith it. We can kind of go through what the staff proposal is and kind of bring up any questions or concerns so that we can kind of work on all of the questions and bring it before we bring it back to you.
Yeah, so for those of you less familiar with this process, this we're looking at now is the coverage guidance, the academic report, the background. There is a separate document in your materials with a specific guideline note proposal that is very similar. So there's overlap, but it's
yeah, the coverage
we haven't.
is recommendations for any payer in the state who chooses to look at it or use part or all of it. And then we have a separate document that Liz is showing on the screen right now. And what staff had recommended doing to operationalize would be, we already have all of the codes pairing on our current sleep apnea line because we already covered for children. So the change would be adding coverage for in the guideline. It currently it says surgery for sleep apnea is not included on this line. That would be crossed out. There'd be a new section, which is Liz will show you in just a second, that is essentially the blue box from the coverage guidance. We would work on what it section B, inadequate response to CPAP. We would work on that to give you a better definition of what inadequate response would be. And then tonsillectomy alone. Oh dear, come now. My computer just froze, but you can see it there. It was essentially also the same wording as in the coverage guidance with the tonsil scale. And we would also do the same wording for inadequate response to CPAP. We would also put that wording in there. And then other surgeries, including MMA and those types of things, are covered for children. And then they have children's criteria. And then we would also need to look at diagnostic guideline D8, which is our sleep apnea diagnosis guideline. And it currently says that DICE, the drug-induced sleep endoscopy, is only covered for children. So that would change to say that it's covered for people with OSA who are being evaluated for upper airway surgery. And the other wording would go away.
And that's based on expert recommendations? Or those are in surgical guidelines covering DICE?
So what we heard from our experts was that they do a DICE before they determine, because they want to see the anatomy of the airway before they operate. And also, I believe Dr. Lamb's on the line, and he can speak to this more closely. I believe he was saying that there are some times where he does the DICE and realizes that a UPPP would not actually be the appropriate therapy. So
It doesn't look like we have Dr. Lamb.
Dr. Lam joining us in the afternoon.
I'm sorry, Dr. Lamb.
He'll be here in the afternoon though, so we can address that at HERC.
So we have 5 minutes. What do we need to do with this as a group? Do we need a straw poll, or do we need to say yes? I mean, the coverage guidance is the coverage guidance. I don't think we have anything to do with that.
I think I would just find it helpful if you have any other concerns or questions or want clarifications or you want further wording, since we're tabling the prioritized list changes until staff can work on the wording. If there's anything else that you want us to look at, consider, bring you more information on, anything else at that point that would be useful, so we can have it all on the table when we look at it again.
I would like clarity of when to go to surgery versus when to go to mandibular advancement device, because that's not clear. It's just fail CPAP. You can have either of those two. It's not really clear from our guideline which one or which way.
Okay.
Or are they equal?
Yeah, and I doubt it's part of our purview, but there is a medication approved for sleep apnea now, and having some clarity on when that all falls in the treatment pathway too, I think would be helpful.
You're talking about the GLP.
We weren't going to go there
Talking about Zepbound, yeah.
but if you want us to work with PNT staff on the tirzepatide kind of question.
Yeah, I mean, I think it should be aligned. I know that they recently approved it based on those two studies. I am not as convinced about those studies, and I think it's very unclear where it falls in a treatment pathway. And I think as far as HERC is concerned, there's decent issues to discuss there and when it would be appropriate.
What do you mean? Like that, I think the recommendation is not.
That's the surgery, not the device.
The
device is already in there. So we covered the device before.
Right. We cover it for when you fail CPAP, but I hear what I hear your question is do we cover it instead of surgery, before surgery, just as
like what's the treatment pathway? So they fail CPAP, then are we going surgery? Are we going mandibular advancement device? Are we going Zepbound? Or if not, like what's the next one based on efficacy, all that stuff, next.
And some of that may be just patient preference or sort of.
Yeah, it could be that too. Sure. But I think making it clear would help.
Okay. So I have things to work on defining fail to respond to CPAP, looking at where mandibular advancement devices fall into this, and staff will work with our DME folks about the fee schedule for the mandibular devices, and then where is the medications in this pathway. So those are all questions you want answered. Any other questions, other areas that you're concerned about or want clarity on?
Is your question on ice?
Anything about
I think we're
that?
talking about this afternoon.
Yeah. All right. Any other thoughts, questions? Do we have any public comments on the last of any kind?
One outside person who wanted to do public comments. It was unclear whether it was at VBBS or HERC. They had comments about a ENT issue. Is that
Dr. Smits, that's for HERC.
okay? And are they okay with HERC? I wasn't clear from corresponding with them which meeting they were planning on attending.
I believe that was HERC, at least according to the email thread.
Okay, they're not here, so. All right, next meeting, August 14th. And are we only going to be online? Is that what that note says?
No, I'm sorry, online and in person.
Okay, hybrid meeting, August 14th,
I believe we're back downstairs.
and somewhere in this building. All right, without any further questions, we will adjourn. I want to do that all the way.
Thanks, everybody.
Thank you all very
Thank
much
you.
for your time and your efforts. Appreciate it, Ariel. Good job.
This coverage guidance.
Thank you.
Yeah. Right.
Correct.
Yeah.
Okay.
All right, so we're on break till 1:30.